So Nitesh, once again, thank you for arranging this webinar on urology learning through others' experience and euroacademy.org website. These two fantastic platforms doing these webinars since even the days of lockdown, and probably this is the seventh or eighth webinar on subjects of pediatric urology, and third in a series with the Professor Margit Fish and other stalwarts from the outside the India. So today we have three excellent faculties from the United Kingdom, along with the Professor Margit Fish and two our Indian faculties. I myself is Anil Takwani. I'm welcoming all the faculties along with our viewers on the ULTO in Euro Academy. Just brief, you all are knowing me now, consultant pediatrician, reconstructive urologist. I have my own kidney hospital, and Junagadh is the westernmost place in the Gujarat, that is in the India also. And there you can see present climate, good clouds, raining in between. And this is what the peak you are seeing is the Girnar mountain.
Anil sir, you have to share your screen. Sorry, interrupting you.
Okay.
You have
okay.
To share
Is
your
it? Is it?
Yeah. Yes.
Okay.
Yes.
What happened? Is it? It's not allowing me. Nitesh.
I think somebody else is sharing.
No. I'm just sharing it, but the probably. So now again, I try share, right? Is it okay now?
Make it full screen. You are fine, sir.
Is it okay now?
Yes, sir.
Okay, so I quickly go and then I introduce my esteemed faculties. We have a Professor Ramanath Subramaniam, who is a pediatric urologist at St. James University Hospital, Leeds, United Kingdom since 2002 probably, and is a present secretary of ESPU, very big position, and he's there probably since last couple of years, and he's a fellow of EAPU and special interest in minimally invasive pediatric urology along with the pediatric surgery, and his academic presence is well known across the world. We have a Manoj Senoy. He's a consultant pediatric urologist, president of British Association of Pediatric Urologists. So again, we have an academic head department of. He's working in the Department of Pediatric Urology and Pediatric Surgery at Nottingham Children's Hospital. He's a very sharp shooter, and I know this because of my conversation with last 2 days. So welcome, sir, and probably we'll enjoy it today. And we have a Dr. Shupul Henayake. He's a consultant pediatric urologist, Royal Manchester Children's Hospital, Manchester. He's a special interest in PUGO, BUR, duplex kidney, and all these three faculties coming from the United Kingdoms, having a lot of presence in the field of academia. We have once again Professor Margit Fish, not required to introduce again. She is third time in this series of webinars, and she is the director and chair of urology department of University Medical Center Hamburg, and she is heading the section of pediatric urology there. She is a fellow of EBU, fellow of EAPU, past president of GURS and EGURS. So once again, welcome Professor Margit Fish, and we have two our stalwarts from the India, Professor M.S. Ansari, who is heading the pediatric urology department at SGPGI Institute, Lucknow, and he's a present council member of Urological Society of India. And we have my teacher, professor and head of pediatric urology, Hemant Pathak sir. He's heading the Nair Hospital Department, Mumbai, and he's the immediate past president of USI, West Zone. So I welcome all these faculties, and I hope that this webinar is going to be a landmark one. And with that, I start introducing my cases. This is the first case, and this is when this child approached to me. She was 1 month. Parents were elderly parents, more than 40 years of age, twin delivery following IVF, antenatal detection of left hydronephrosis, and right kidney not seen in that particular sonography. She was having a continuous waiting, 6 weeks age thereafter. At that time, she was 3 kg weight, and at 10 weeks, she was 4 kg weight. So she was picking up her weight, though in spite of all this problem, she was non-breastfed. And this was the sonography picture. This is the sonography picture which was taken at the 6th post-birth day. Very difficult to read. I'm sorry for that, but this was the exact picture which was provided to me by a sonologist who is almost very much familiar with the pediatric urology sonography. And the cortex was 2 to 3 millimeter, pelvis 30 millimeter, and lower ureter dilatation was almost 16 millimeter at the bladder level. And the serum creatinine was 0.49 at that time. Subsequent to that, we did voiding cystoscopy, and she was kept on antibiotic prophylaxis. And there's no reflux, bladder is normal, no ureterosil, no outlet problem. Hello. And this is the diuretic renal scan at 8 weeks. There you can see split function. See, diuretic renal scan could show some functioning mass adjacent to the left kidney. The functional uptake of the right kidney was 37.8, left 62.2. So I would like to ask the first questions to our panelist, Professor Hemant Pathak. Could you make the diagnosis from these provided details? Nitesh, someone need to mute those who are making too much of noise. Can you please mute all the people other than these 6 or 7 faculties? Nitesh, please mute all the. Yes, sir. Hemant, sir.
Now,
would you like to make a diagnosis based on the sonography, VCUG, and renal scan?
No, I think
sonography was suggestive of left side very gross hydroureteronephrosis, and the right was not seen. But on the renal scan, we can see some functioning renal mass. Sir, I am not able to listen your audio.
Now can you hear me?
Yes, sir. Please.
See, now you have given us the information that the right ureteric orifice is seen, which was normal, orthotopic, and left ureteric orifice could not be identified.
Yeah.
With this information about the left, which is grossly hydronephrotic, hugely dilated ureter,
yes,
thinned out cortex, hardly anything. I would, like solitary functioning kidney. Now, before I plan anything, I would like to have an antegrade study. I would puncture the left kidney and image the left kidney and the ureter before I plan any further.
Professor Ram,
yes.
Have you made your diagnosis with the available investigations, or you will add something like Professor Hemant Pathak want to add the integrate study, which didn't strike in my mind at that time?
Yeah, I'm actually a bit all confused at the moment, so I'm not able to make a diagnosis. So I just need, when I saw the slides initially as well, I need a lot more information properly before I can decide what I want to do.
Right.
If you go to your first slide, you don't mind. Yeah, I mean, this is showing, which I have to assume there's only one picture there, so it's quite difficult for us to see.
Yes, sir. This is a renal level picture.
On.
Yeah.
So we have to accept what you tell us, that it's a 30 millimeter AP diameter with a thinned out cortex and a single large hydronephrotic kidney, and the right kidney was not visualized, which sort of surprises me a bit because ultrasound scan is very sensitive to pick up kidneys and stuff. So if they haven't seen it either on antenatal or postnatal, that sort of worries me.
Right.
If you go to the next slide, that shows no evidence of reflux, which I will buy it. That's not a problem. There doesn't seem to be any ureteroceles, so that also is okay. If you go to the next slide, then that brings a lot more confusion than actually answers. So it depends on what type of scan this is. Was this, when you say diuretic, was it a
EC scan, sir?
DTPA, MAC3?
No, it was EC scan. EC scan.
Sorry?
EC. Diuretic EC scan.
Diuretic excretory scan, is it?
No, these radioisotope was EC.
ECO, I'm not familiar with EC at
Yeah.
all, because what
See,
we use is just
we don't have a
MAC3.
MEG3. So instead of a MEG3, to have a tubular extract, almost similar to the MEG3, we use EC. And rather than the DTPA, this we have discussed in the first webinar. Professor S.S. Joshi pushed all of us to use EC whenever we ask for the diuretic renogram, as we don't have availability of MEG3.
Okay,
But
okay,
we have
anyway,
availability. Yeah. Okay.
That is okay. I accept that, which I don't know, but never mind. That's not a problem. The issue you have here is, if you look at the bottom left screen, it doesn't really add to show where is the functioning mass on the right or the left. If I read this image from posteriorly, then the functioning tissue seems to be on the left hand side, and that doesn't seem to be any functioning tissue on the right hand side. So the way the radioisotope study is conducted and reported, they have a field of interest. If you look at this image, on either of those images, I'm not convinced as to what's going on. There is some blur of activity on the right hand side, and with that dilatation of the left kidney, then 62% is spurious function on that left hand kidney. So overall, I don't think we have all the answers, although the cystoscopy
and Professor Ram, if you notice the appearance of the radioisotope gradually, see, it has come quite late on the left side. If you see that it is uneven distribution as well as quite late distribution, late appearance.
Yeah, I know, that's what I'm saying. So it all depends on when the images are picked up. I don't think it's accurately telling us where we are.
This is every 2-minute frames.
Okay, but what I'm trying to say is that I'm a bit not sure at the moment for making a 100% diagnosis.
Perfectly agree.
But I wouldn't do in my practice. I don't do invasive investigations like Hemant has suggested. I can see why Hemant wants it, to look at where the site of the problem might be. But I would get much more detailed information from the cystoscopy to see what I can cannulate.
So cystoscopy, I could not identify the left ureteric orifice. And
but that again confounds a problem, you see, because you have ultrasound scan does not pick up right kidney, but you're seeing the left orifice. So
no, right orifice.
I'm
seeing the right orifice, orthotopic, and left I'm not able to see.
Yeah.
Which is apparently appearing the obstructed on the sonography as well as on the renal scan.
Yeah, but antegrade picture alone is not going to give much more invasive investigation on a child. So we need. I'm not convinced at the moment of time that I can.
So that was the similar dilemma was going on in my mind, and I posted this case for discussion almost before 4 months before the lockdown on our small WhatsApp group, and we had some discussions during that time. And the patient went to the other center for the second opinion before they came back to me, and they came with this CT scan picture. So I am posing here for the further radiological investigation. Suppose in these circumstances, would you have preferred MRU or the CT scan? And can you speak a little bit on the excess of the use of CT scan? I would like to have a small or brief comment on the excess use of CT scan, probably in the pediatric urology group patients. Yeah.
Okay, I will just finish off because I said something earlier on in one line that I have never used CT scan in practice in pediatric urology at all for any of my patients.
So it's a major statement, and that is very much.
The only indication is trauma. When you might do some CT and that thing, but
why Ram, I'm asking this very repeatedly in last couple of webinars is that even in a USI webinar, that if you see the trend, even if you be member of ULTO group, which is having more than 6,000 members and posting case day in day out, and most of the time they start with the posting the CT scan, even of the pediatric urology patients, just dilatation or UPJ dilatation or VUJ dilatation or anything, and they just get the CT and they post first pictures of a CT to initiate the discussion, in spite of or despite many comments and requests from the many stalwarts like Professor S.S. Joshi, Venugopal sir, many of us, but the scenarios are not much changing. So your words are quite hard-hitting words and very much important for all of us.
Yeah, so what I'm trying to say is that if you need further investigations in this sort of circumstances, then an MRU is a better investigation. The difficulty with MRU is that you will need, in a small child, you will need an anesthesia.
I think, but
to
that
actually
is
get good
perfectly
images.
all right. The small anesthesia nowadays is not a problem, even a place like Junagadh, which is a peripheral center, rather than subjecting child for this massive radiation involving CT scan.
Can I add something there?
Yeah, yes, sir.
So I would agree with what Rama said. The role of CT for imaging, especially in this situation, is we would not do that in the UK. Most places would not do a CT. Now, his comments about indications for CT in pediatric urology, I would say one is trauma, as Rama said. The other is, of course, stones. So in stones, you would end up doing a CT for looking at the calyceal anatomy and things. In this particular situation, I think the investigation that you had, the ultrasound and the radioisotope study, they don't kind of correlate with your findings at cystoscopy. So personally, I would do an MRU with GA. That's what, if you want someone, not a CT.
Perfect. And this is just to sum up on the CT scan. I was reading one of the article published from the USA. Even in the USA, there is a 10% increase in the CT scan, contribution of CT scan in the diagnostic armamentarium in the USA. And almost 50% or more than 50% radiations are coming from the CT side. So that is an alarming, and this is not our Indian data because we don't compile the data here. But this is the almost 2018 paper published there, and they have talked this issue very clearly, that we should definitely restrain using the CT scan in this kind of when we are discussing the just hydronephrosis or hydronephrosis like conditions. Yes, Professor Margit. Yeah.
Yeah, I fully agree with what was said. I would never ever do a CT scan in such a case. I would have repeated the ultrasonography, because if you have a good department of ultrasonography and if you do it yourself, you will get at least 90% of the information. And I'm quite sure that it would not even be necessary to do an MRI. But if I have to decide what to do next, I would also do an MRI. And I fully agree, CT, you may do it in trauma and in elderly patients with stones, not in the very young ones, because in the majority of cases, you can do the diagnosis by ultrasound.
And it may be, if required, what we do in our practice for the stone is that limited plate IVU sometime. Yes, Dr. Pathak, you want to make any comment? Or otherwise I go on a further discussion here.
Comment means, our issue is the level of obstruction.
Yes, sir.
So finally, we have to see which either
Sir,
MRI or
MRI.
in our setup with this scenario, when I take him up for a cystoscopy, the same sitting, if now in this situation where you have mentioned that you couldn't see the left orifice, child has been anesthetized for cystoscopy. We don't.
Sir, the cystoscopy was done actually after this CT scan. Sorry for that.
Whatever it is. Now, see, what I'm trying to say is, if you have taken the child for us, you have anesthetized the child, you can't see the orifice, left system is grossly dilated, ureter is dilated. I would now, in the same anesthesia, do an antegrade study.
Okay, Dr.
The level of
yeah,
obstruction.
perfect, sir. Dr.
Iman,
Supol, you want to make any comment?
Anil, can I just qualify a comment? I think what Margit was trying to say is actually that with the help of an ultrasound scan, you'll be able to map the anatomy significantly in more than 95% of our cases.
Absolutely.
With an experienced pediatric radiologist, or even yourself if you're used to doing it.
See,
but
I'm really blessed to have an expert radiologist. Yeah.
Anil, 1 minute, let me just finish. What I'm trying to say is, to bring back Eamon's point, is that, Eamon, the question here is not level of obstruction actually, because we know the distal ureter is significantly dilated. The level of obstruction is somewhere along the lower end of the ureter or somewhere in the bladder. That's what we know for sure. There are two questions here which are really significant. One is, what is exactly happening in the right kidney? Because we really need to know that. And I'm not so sure from that point of view. And so the level of obstruction is not the real issue. The issue is which side is affected and what's happening to the other side. That's what
Okay.
I'm more interested
Perfect.
in.
So we go ahead with the discussion. We have unfortunately, but CT scan, Dr. Supul. Would you like to make a diagnosis now with the help of the CT scan findings?
Can you hear me okay?
Yes, sir.
So actually, the ultrasound and the isotopes can actually give me adequate information, I have to say. And as Margaret mentioned, if I was not sure, I would have asked for another ultrasound scan. So as soon as you showed me the ultrasound and the isotope scan, I could see that the right kidney was a little smaller and it was in ectopic position towards the midline. So that is why the radiologist couldn't pick that kidney, because it was not in the normal position. It was covered by the bowel loops. But the right kidney, at 37% function, it is working as much as it could. I think it is pretty much a normal kidney. Now, regards to the left kidney, it was pretty clear that the left kidney was having some function. You could see the isotope in the periphery. It took a while for the isotope to come into the pelvic ALCL system. And by then, the right kidney, which was in the midline, has drained fully. So the right kidney did not have any obstruction. It was draining nicely. The left kidney was working. You could see the isotope in the periphery very clearly. So it is, I agree that it may have equal function or even better function than the right kidney. And it is clearly, there is obstruction at the lower end. It could be a very tiny ureteric opening in the bladder, which cystoscopy sometimes fail to find, or it could be ectopic ureteric opening.
Yeah. Perfect. Sir, so you are making the diagnosis here. And what you will propose as a treatment, sir?
MR scan is not going to add anything to this, right? So whatever the best MR scan cannot show exactly the lowermost point of the ureter. And as Ram says, it is not important to know exactly where the lowermost point is going. Right now, the importance is this child thriving? Is this child managing without any urine infections? Knowing the history of a large congenital megaureter, knowing that the infection risk is fairly high, maybe up to 15 to, maybe 12 to 15 times higher than the normal population, right? So you may want to do something if the child is getting urine infections or if there is failure to thrive. So with such a significantly dilated ureter, if the child is having UTI or failure to thrive.
Sir, child was not having a history of UTI.
Is a child failure to thrive?
No, that was not that significant. I gave you 3 weights at almost 6 weeks, 3 kg, 4.5 kg at 12 weeks. And right now she is of gaining the good weight, but that's perfectly okay. So there was this initially concern was solitary kidney. Now concern is the right is a smaller kidney, which is ectopic in position, fused with the left probably, and the left is hugely dilated, maybe obstructed or not obstructed, but there is no clear-cut history of say infection. There is a constant waiting that particular area of the urethra opening. Yeah.
The other important thing which we practice, I think, everywhere in the world, is to have a frank discussion with the parents and explain that it's a complex pathology here. But I would reassure the parents that the right kidney is good, even though it is in an ectopic position. I think it would continue to function very well for the rest of this child's life. That there may be some degree of dysplasia on the left side system. I wouldn't call it real obstruction because the pressure in the system would not be very high because the ureter is taking all the pressure, brunt of the pressure. So the kidney parenchyma may be well maintained, but obviously we would know whether there is continuing pressure by monitoring the dilatation on ultrasound in a real objective manner. If it is worsening, I would say, okay, maybe we need to do something, even if the child is putting on weight and not having urine infections. But I would have a frank discussion and say, okay, we can manage conservatively for the time being, or our option would be a cutaneous ureterostomy if the child is having infections.
Which type of ureterostomy, sir, you will prefer?
Cutaneous ureterostomy.
Where exactly you will be doing? Where exactly cutaneous ureterostomy?
Glomus ureter would be pretty fine actually. I mean, the stents and things, they are plastic foreign bodies, they can cause.
Perfect, sir. But I agree with the ureterostomy. Where exactly you will do the ureterostomy? Which area?
Ureterostomy.
Okay, perfect. Perfect. So you have two options. Either you will keep the child conservative and continuous observation and antibiotic prophylaxis. And second option is the ureterostomy as a diversion. Okay, perfect. Dr. Manoj, would you like to add anything on this, or you differing on these management options?
What I would say is that if firstly the child is asymptomatic, then there's no need to intervene at this point because the child is too young. We shouldn't just treat X-rays. We should treat the child.
I waited till the almost 2.5 to 3 months in this child.
Yeah, it's still early days. The child is still very small, so
Right.
there's no rush. If the child is asymptomatic, is thriving, no UTIs, I would wait. There's no rush to do anything. I would wait and take the
Okay.
child at least to a year of age. If the child has recurrent symptomatic upper tract UTIs, which need intravenous antibiotics, then is the time to intervene, not before, in my opinion.
Okay, and that circumstances, in that case, you will be keeping child on antibiotic prophylaxis.
Yeah, you keep the child on antibiotic prophylaxis. If if the child has had say one UTI, I wouldn't intervene with just one UTI.
Do you think this 0.47 creatinine, which was done probably at the weight of say 3 to 4 kg in a 1.5 month child with the height of something around, do you think that this creatinine is perfectly okay, or maybe this glomerular, if you exactly calculate the GFR, maybe this GFR is little bit less in compared to this what it should be.
I'm not now.
Are
very
you concerned
familiar-
about the maybe some deterioration of function if you wait? No, you don't.
No, I'm not very familiar with the creatinine values now. I've left Bombay about 25 years ago. But in your terms, what GFR would that give? I know it's very not very correct in this age group, but
Yeah.
is the creatinine in the upper limit of normal, or is it?
Yeah, it was as per the laboratory at this age, it was definitely within the upper border of the limits.
I would still wait. I wouldn't dive in and do anything at this.
So, Professor Ram, would you like to add anything on this discussion, or it differs?
Yes, yeah. Well, yes, I would like to. I think
Yeah.
I would manage conservatively because you have to involve the patient. You got to talk about the patient. Hypothetical situations doesn't help the situation, right?
Right.
You told us the child is clinically well. There is no
Yeah.
infections. The child is growing. I would wait. Okay.
Okay.
I would
perfect.
wait as long as possible. Whether I give antibiotic prophylaxis or not is a different argument. My policy for giving antibiotic prophylaxis is for any patients with a mega ureteric dilatation. Okay, I would give antibiotic prophylaxis. If it is pure pelvic-ureteric junction only hydronephrosis without any hydroureteronephrosis, then I would not give antibiotic prophylaxis.
We are absolutely agree, Ram. We
Okay,
have discussed
okay.
this issue
So-
in a previous webinar. Yeah, we agree.
That's fine. So if the circumstances, clinical circumstances change, okay, here I would like to disagree with doing any diversion unnecessarily.
Okay.
We have
okay.
to worry about the bladder.
Okay.
If you just start, you got to first know exactly where all the anatomy is and then decide what we are going to do. But a diversion at a ureterostomy level is not a decision that I would lightly take.
Okay.
I would wait. If at 12 months of age, if myself, with my knowing what I can do surgically, if I come at 12 months of age and the child is having some infections and I need to do something about it, and I'm confirmed he's got an obstruction in the lower end, I am comfortable to go and re-implant the ureter. I do not have these big fears of bladder dysfunction and stuff.
No,
because
I'm
of
coming to that point. We
I
have
think-
one
I
additional
think
case in
technically,
this.
I think technically, if you are comfortable and you are okay, it is better than doing a ureterostomy.
So
in
Ram,
these
let me add one more information that while we were discussing this case, because I was also in a dilemma, I'd never operated or reimplanted or even shorted refluxing reimplantation in previously at this age group of child. And child was moved to the another opinions also, but at around say almost 11th or 12th weeks, it developed a mild sort of infection. It was not a febrile pyelonephritis which required to admission. but she was required a therapeutic dose of antibiotic, and then subsequently on again prophylaxis. So with this information, would you like to change your any of all of you, those who are preferring the conservative approach, would like to change? And if you change, what would you like to do a procedure?
Was the child on antibiotic prophylaxis before the infection or not?
Yeah. Child was kept on antibiotic prophylaxis by the pediatricians with the first sonography, which was done further away from the Junagadh, that is where our Somnath place.
Okay, so the next question to you is: there's nothing like a terminology of a mild infection. There is no mild infection.
It was a urine
Is
tract
there
infection,
infection
not with a fever. It was
no.
not a
Is the
febrile.
infection?
Yeah,
so
there
it's
was
a non-febrile UTI.
Yes, non-febrile UTI.
Okay, was the counts and cultures grown something or not?
Yes, culture grounds Klebsiella and count raised to the 14,000, but there was no
but
fever.
sensitive to what? Sensitive to what?
Sensitive to the almost all antibiotics, for example, cefixime, as well as the nitrofurantoin and amoxicillin, like this.
Okay, at the first point of infection during conservative management, I would go by the culture. I would change the antibiotic prophylaxis appropriately and then see what happens. Still, I would manage conservatively for the first infection. I'm not going to rush into it, but I will monitor that situation closely, guardedly as to what's going on.
So it's a very clear message that all of you are agree on initial conservative management. Perfectly all right. Now, suppose if you have a febrile UTI and you are forced to do something, that what you would have preferred in this child as an intervention?
Say again, Anil.
Yeah, suppose this child would have developed a febrile urinary tract infection, a breakthrough infection, suppose after a month. What procedure you would have preferred, or still you would have continued with the antibiotics?
Okay, I will let other people speak, but for me, if it is confirmed that the child has got a left vesica-ureteric junction obstruction, okay, and the right kidney is otherwise okay, then I would still do a reimplantation at this child. If this child is getting infections that is not controlled with conservative management, I am very comfortable doing a reimplantation, no problem.
So you will be doing tapering with the reimplantation straight?
It depends. Whatever I will go there and I'll decide, because sometimes when you have this dilated and you reduce the size, then you got to decide on table you want tapering or not. So the answer is correct. Reimplantation plus minus tapering.
But though we don't wanted a CT scan, you have a CT scan picture there. You can see that it's hugely tortuous and significantly dilated ureter. Definitely we decide after detaching it from the obstructed segment on table. So what is your parameter for the tapering? After detaching, what size you look to decide for the tapering?
Okay, I don't go by sizes. Is what I'm trying to say. It depends on size of the bladder. It depends on, can I accommodate this ureter comfortably within a wrap? If I cannot accommodate comfortably within a wrap, I will do a tapering. That's the basic answer about it. So most likely, yes, in this case, I have to taper, but that's fine. I'm quite happy to do it. But there are ways of doing a tapering, which we'll come to later on.
Yeah, we'll come there. So Dr. Ansari, now I want to bring you, see, you have listened the discussion, so I'm not repeating. Want to make a point?
Yes.
Please go ahead.
I just wanted to comment about what is the role of minimally invasive surgeries in infancy.
For example,
like
double J stenting, endoureotomy. What you want to say?
I am specifically asking double J stenting because everybody will not be very versed with reimplantation within 1 year.
So do you practice double J stenting in a SGPGI?
Yes.
In such scenario?
Yes.
Have you
Can I make
published,
a
sir?
comment on that?
I'm coming to you, sir.
Yes.
Let me finish with the professor.
Yes, I just can give, because in 2013, I think there was a BAPU survey published in Journal of Pediatric Urology.
14, I'm bringing that point.
Yes.
Yeah. So this is something.
Very interesting.
This is something about the BAPU survey. Second comment, consensus statement on management of primary obstructive megaureter, BAPU 2014.
Yes.
Yeah.
So I just wanted to know what is the current practice in UK from the same country.
Yeah, Manoj, would you like to comment further? Yeah.
Yeah. So first things first. So the one febrile UTI will not necessitate surgical intervention, in my opinion, in an infant. Recurrent febrile UTIs is a different issue.
Perfect.
I prefer.
But if you are forced in this condition.
Yeah. So I'm coming to that. So if you have to go down a surgical route, my preferred option would be to do a cystoscopy and using a Terumo guide wire, try and stent this. We have done that for many years now, even in children with solitary kidneys. Take an
Sir,
exchange
this
stent
child
that-
was giving history. Parents were giving clear history of continuous wetting if the urethral, external urethral area.
No, I'm talking.
Yeah.
No,
I'm
talking
just telling you that in this patient, suppose, and second thing, definitely I would like you to share your experience with the stenting and how far it works.
Yeah. So if you're talking about primary obstructed megaureter and intravesical with an intravesical opening, that
Right.
would be my preferred option.
Right.
Right. So I would do a cystoscopy and use a Terumo guide wire, an 018 Terumo guide wire, and put a double J stent. And we have exchanged stents just before 6 months and taken children up to 2 years. We have not
Okay.
had to intervene or do a reimplant in this group of patients. And our
Okay.
patients are followed up systematically. We've got 7 nephrologists, and we follow them up very systematically.
Okay.
We have
So
not
thi-
had to intervene.
So
If-
this is a very major statement, sir. Very major statement, and you have a probably very long-term follow-up.
Yes, we have.
Yeah, okay. And what means you can look at the screen. I'm just quoting this 2018 article published in the Journal of Pediatric Urology by the Karim and his group. That is complications of almost 14% in the form of incrustation, migration, hematuria, UTI, instrumentation, and the long-term success rate only 26% as a sole procedure, as it failed in all cases more than 12 millimeter dilatation. Your say on this comment?
Yeah. So when you look at what do you mean by success, and it depends on what your outcomes are. So long as the child is asymptomatic, if your dilatation, you will never get down to normal caliber ureter on a follow-up scans, even if it's a reimplant or whatever you do. All that you're looking at is symptomatic improvement, making sure that the kidney function is stable and there is drainage. Those are the 3 things that one would be looking at. So if it depends on when you say, what do you mean by 26% failure rate? I'm not sure.
It said that the success only in 26% as a sole procedure, means they didn't require to add anything over this, and specifically they observed this finding in a patient having a more than 12 millimeter dilatation.
So our criteria, again, I'm coming back to the same point. It doesn't matter what your diameter is. All that I'm trying to say is that if you have recurrent, our criteria for interventions are recurrent febrile UTIs, whilst the child is on antibiotic prophylaxis. And if there are breakthroughs, it's only then we would intervene. So that is one option.
Anil,
So
Anil, can I come in?
I'm coming. See, just I want to inform you that if all people are ready to stay with me, we'll extend the time. It's a virtual meeting, no limitations of the time. But Margit probably will leave us after 2 hours because we are almost 40 minutes. By this time, we are ending at the worst case, and this is the story, Ram, in a previous 2 webinar, and I am enjoying. So
No,
I
I'm
hope
not
that
want to
all
take
of you
too
are
much.
enjoying.
Anil,
Yeah.
it's not important. That's the important point you're making. But I just
Yeah.
want to say
So yeah, please,
is that
please
on
make
this
your
point
comment,
about
yeah.
stenting, it's important to make this point about stenting.
Yes,
okay?
absolutely. I
Okay.
also want to, but you
Okay,
first start,
although I
yeah.
live in the United Kingdom, I do not believe the Bapu report. I do not believe it. Okay,
Perfectly, I don't also.
yes, I'll tell you why. And the second paper of 2018 is more accurate to my experience and belief than what Bapu is suggesting. Bapu never looked at the degree of dilatation and the ability to satisfactorily stent a tortuous megaureter.
Absolutely.
Many of us in this room are experienced enough to know that if you have a significantly dilated ureter, you may never succeed in tenting it properly. That is first problem. The second is that if you have a less dilated ureter and a sort of a sub hold at the VUJ, you can stent it and dilate it. But those patients who have got a significant tortuous dilated ureter do not settle with stenting alone.
Absolutely
So I'm more
agree.
inclined to believe the 2018 paper that less than 30% will be successful, and it depends on case selection. So
Yes.
it's not a treatment that you can advocate for these patients.
Okay. So I talked to even Manoj beforehand that we will be having a lot of controversies, and it will be very difficult time for me to finish these 6 cases only. But anyway, any of these, see, we have a messages. So any of the faculties want to make a last final comment on this? Otherwise, I go to the Margit.
Yeah, 1 minute, Anil.
Yeah, yes, sir.
So I think, before we, one thing is very clear, at least in our center also, once the diagnosis is made, and Dr. Supul also mentioned about the right kidney, which probably a sonologist was not able to pick it up. but the renogram shows a reasonably good function.
Yes, sir. Make
So the
your point, sir. Yeah, please.
So the management essentially will be conservative,
Perfect, sir. Perfect.
till at least 1 year, 1.5 years, 2 years. Once the child has grown, then I would definitely plan intervention as much later as possible.
Okay, perfect. Perfect. So in these patients,
one small point, if I may.
Yeah.
If you want to do anything different, what you have suggested there is, transecting the ureter and doing a end-to-side uretrovesicostomy. What you could do is leave the obstructed segment alone and
I'm coming to that point now. See, please give me a little minute, 1 minute. So in this patient, because of a fear, when the child developed UTI, I changed my mind. I agree with all of you that I would have continued still with the conservative treatment, but then I decided to go ahead with actually wanted to do ureterostomy, but then in our small group we discussed, SS Joshi, many other my friends, they all they advocate me for a refluxing sort of reimplantation, where we moved for this detaching it from the obstructed area and then do an end-to-side anastomosis with the bladder. I did it, and my experience, I'm just sharing that I did first time. It was not that easy. It was not that in compared to the ureterostomy, diverting ureterostomy, it was a much difficult procedure. It took longer time. There was some anesthesia. Child remained on the tube for a couple of hours, and thereafter she came out, and she's doing perfectly well. And these are the sonography picture of the same child. Yesterday it is done just for this webinar to accommodate. This is according to the sonologist, this is the right kidney here, and this is the appearance of the left kidney now. And last picture is of you can see that this is can you say that bladder and a refluxing sort of ureter. So child is presently of a creatinine of 0.42, which is also under the control. She was kept on antibiotic prophylaxis that she stopped because of some lack of communications during the lockdown period. And this is the fresh sonography picture. So what I'm trying to share is this is what I have done. What I experienced on table was it's a difficult procedure. And thereafter, when I was discussing with the Professor Ansari, he said that don't detach it and do it side to side. So we'll have some comment on that also. And last is that this patient was waiting, but now she is 7 or 8 months. She is having of almost 7 to 8 kg weight, and she is not having any waiting. She is very frequently voiding. The reason could be the large amount of urine is getting refluxed and it's coming back as a pseudo residual, and that's why probably she is waiting very frequently. But otherwise, she is perfectly well. So with this, Professor Ansari, you was talking about me about the side-to-side anastomosis without detaching. Yes, please.
Yes.
Share your experience.
Yes, if you dismantle it from the VUJ, it has a redundant ureter length.
So that was an exact problem with me. That it took me a lot of.
What I will suggest you, wherever you get the easiest way to contact of the ureter and the bladder, just do the vesico, this ureterostomy. That will solve the problem.
Now, suppose, sir, I got that point. It's a beautiful deviation, and there is this paper in 2017 in J Urology that they succeeded almost in 25% out of 27 without doing additional procedure. When they have done a procedure like me, they could succeed at only one to avoid the definitive reimplantation. So it is very much striking. But suppose if you have an ectopic insertion with incontinence, for example, and you are doing some this kind of procedure, I think still you can go ahead with the side-to-side anastomosis, or no, you have to do refluxing end-to-side anastomosis.
See, even if you can do side to side in an infant, which is most of the time in diaper, it hardly makes any difference.
Okay, perfect. Manoj, you wanted to do some last comment on this.
Yeah, no. So I agree with what Dr. Ansari has said. So if you talk to Martin Kiefer, so in a setting like that in an infant, it's best not to go at the VUJ. It's best that you do a side-to-side uretrovesicostomy.
I agree. Absolutely, from my experience, I agree.
Yeah, and that is the quick way, and so you wouldn't have to do a lot of dissection as well.
But still, you can see there is a lot of regression of the hydronephrosis. You can see a good cortex in this particular picture. Maybe she has grown, and that's why kidney has probably grown. I don't know, but you can see a good cortex here. Dilatation is definitely different. Maybe could be advantage with this kind of a procedure or not. I don't know, but child is doing fairly well. Now, Margit, would you like to go through these slides very quickly before I end this case? Yeah.
Yes.
Could I make a comment, please, Anil?
I'm coming, sir. Let Margit to finish these slides.
Okay.
These are the
So-
slides waiting since long with me.
So for those who are on training, I just put a
Yes,
couple of
that is your
literature
purpose. Yeah,
together.
perfect. Go ahead.
So we have to deal with the left-sided primary obstructive megaureter, and we have an ectopic kidney on the right side. So the primary obstructive megaureter is rare. It's 0.25 to 0.36 in 1,000 newborns. In around 20 to 25%, it's bilateral. Boys are more often affected than girls, and we see vesicoureteral reflux in about 10 to 15%. And as mentioned on this slide, you see other anomalies, and this child has the ectopic position of the right kidney in quite a high percentage. So we discussed, should we do antibiotic prophylaxis, yes or no? And there are some data out that we should do it, at least in the first year of life, as there is a 12-time increased risk for febrile infection. Let's go back. And 19% of these urinary tract infections are during the first year of life. However, these are retrospective and no prospective data. So next.
But you recommend?
I recommend, and if you go to the literature, it's recommended. This is a very old slide. These are IVUs out of the year the 80s, and you see the same child growing up. And this is a slide my old chief often showed, because he said, have you ever seen a primary obstructive megaureter in an adult? And no, what is left, and you see that in the middle, is a segmental dilatation. So that means by increasing length of the ureter, then the megaureter disappears, and therefore conservative treatment is the therapy of choice. Next. So interventions are only necessary if you have symptoms, if in the long run your split renal function goes down, in an older child, if you see an obstruction in a MAC3, if you see an increase in dilatation in the ultrasonography, or if you have the combination of obstruction and reflux. Next. So what's the probability? And there are also some data out, prenatally detected, and then during follow-up, only 6% will need surgery, and the majority, the vast majority, up to 19% at least, you can do a conservative treatment. So over the whole literature, only approximately 25% of your patients really will need an intervention. Next. So I prefer, and it was already discussed, a neoimplantation.
We'll come to this, Margit. We'll come to this in the next probably case.
Okay.
Yeah.
So
this is your last slide. Yeah.
We discussed the ureterocutaneostomy. I prefer a high diversion. I do a pyelocutaneostomy.
How often you forced to do this in your say last 20 years?
Only during the first 6 months. If the child has recurrent febrile infection, then I leave the conservative approach and do that. And I leave the connection to the bladder untouched. And you will see in the long run that of those children, only a small percentage really will need a neoimplantation. If you do something down, then you are forced to do a secondary reimplantation at any time point. And therefore, I prefer that. And it's very easy, no stenting, you just put a diaper on.
Okay, perfect. So this is probably your choice and your reason for having this choice of a diversion. Yeah. Okay.
But only if the child is symptomatic.
I'm ending this case on a one minute quick comment from all the faculties, and then we'll run for a second case. Okay, Ram, 1 minute.
Okay, 1 minute. I cannot understand
please.
The paranoia and the challenge about doing a proper reimplantation, dissecting the vesicoureteric junction. I cannot understand that. There is no need to get such panic. If you go extravesical, you can dissect the entire thing right up to the cone, disconnect it, and do a nice extravesical Leach-Gregoire reimplantation.
I perfectly agree. Ram,
there is too much paranoia about dissection about that.
But in this particular patient, I don't hesitate.
Anil, anything alternative is actually trying to get a shortcut, and then that's just too much worry there.
I agree, but there was some risk of anesthesia in this child, and probably that was one of the reason that I was a bit hesitant. But it took me almost 1.5 hours to do this refluxing anastomosis, and probably I would have done a bit more and could have been successful replantation. What exactly you are telling? So I agree, but let other two also have a 1-minute comment. Manoj.
Yeah, so I would only intervene in an infant with recurrent febrile UTIs. I wouldn't dive in and do a reimplant, so I wouldn't do that. I would attempt to stent first, or at worst, maybe do a Kiefer side-to-side ureterostomy and then see what happens.
Perfect. This is excellent idea of the side-to-side learning point for me from you and Ansari. Dr. Supul.
When I need to intervene, if the child is less than 6 months of age, I would consider kidney ureterostomy with a very dilated ureter and recurrent UTI because it provides best drainage of the system.
Okay, perfect, sir. Perfect. Ansari, Dr. Ansari and Dr. Hemant, if you have any additional point, then we move on a second case.
I just wanted to make one comment, Dr. Anil.
Sir. Sir,
we should not forget that POM is also had a very stipulated natural history. Even up to 80% of the babies, they can come out and may not need any intervention. That is my one take on this.
Okay. Dr. Supul, a small request from the audience, those who are viewers, you have to increase a bit of your audio.
Okay, right. I'll do that.
Yes, perfect. So that request came just now from the viewers. Yeah, please.
So
that's perfect. That's perfect. Yeah.
The refluxing ureterostomy, it's a pretty easy thing to do, side to side.
Right.
I do it in older children, slightly older children with recurrent UTI. Right. Only thing, Anil, you have to be careful or worry about is the ureter can accommodate a lot of urine.
Yeah.
If it's a large, tortuous, dilated ureter, it can accommodate a lot of urine. And one child did not pass urine for 24 hours, and the child needed catheterization intermittently to get the bladder empty, because the urine for whole day's urine or even more than 1 day urine could stay in that ureter, right? So that is a problem with the refluxing ureterostomy.
But my patient is having a different experience, sir. They say the parent is saying that child is passing more frequent urine. The reason could be, I said that as a lot of urine refluxing coming back, and that is the reason why there is a pseudo residual and high frequency. Or maybe because of it is hyperfiltration from the damaged kidney. I don't know exactly, but in my little bit of experience of couple of these cases of say diversion. Okay, fine. So we move on Ram, with your permission, we move on a second case. This is what Manoj sent is a response, and this is all discussed. So we go ahead with this next this adjoining case, where exactly I wanted you to discuss, Ram. Because see here, this patient was having this renal level sonography. This is a bladder level sonography. You can say that sharply terminating urinary can at the bladder level. Patient with a febrile UTI admitted, treated with antibiotic. Again, E. coli was the organism. Gross right HUN with bilateral level USG suggestive of obstruction. And this is the say 15 millimeter at the right lower ureter, measures 10 mm, epi diameter 15 mm, cortical thickness only 5 mm. Patient was having a twice infection. This case was of 2015. VCUG, there is no reflux again. And then this is the findings of the diuretic, you can say DTPS scan. At that time, we were getting only this scan, right? This was done at the age of 7 or 8 months, and this is the exactly findings into this. You can see that cortical transit time is delay. There is a diuretic curve is not coming down, and then you can see that split functions still are in the range. But if you see the delayed and erect posture film, there is a lot of retention of radioisotope. If you look at the kidney, which is appears to be obstructed, as well as the bladder level. So this is the very brief story, and then I went ahead with this patient with the reimplantation, tapering without tapering. Here, this was the long, you can say dynamic or atretic sort of segment. There you can see after detaching, there is nothing, no urine spurting. That opening it, thereafter after dismembering and spatulating it, it started pouring. But forget about these slides. These pictures are of not. If time permitted, we'll discuss about the method of tapering. And this is the prior to surgery sonography. This is at the 4 months after the post-operative period, and this is just recent. Means this is I got just 2 days before I called this patient just to have this fresh sonography for this discussion. So this is most recent 6 years post-operative follow-up, and this is the how I manage this case. Ram, your comment, brief comments.
No comment. Well managed. Very good.
Thank you. Thank you.
That's what I want to see. Yeah. But I just want to put in a word for robotic approach here.
Okay.
Because it's magnificent to do robotic extravesical reimplantation without going the bladder. But otherwise, fantastic. Well done.
So regarding the approach, also I wanted to say that whenever it is sort of this case, I approach extravesical, like what you mentioned. Maybe you are going through laparoscopy or robotic.
Yeah. No, although in England we trained with Cohen's quite a lot, but actually in these cases, extravesical is just beautiful. Absolutely beautiful.
Same philosophy in my practice. For rest of the things, I do Cohen's, or you can say Fulton a little better, but for this extravesical. Quick comment from Manoj. Manoj.
Yeah, I wouldn't do Cohen's, though Ram is saying we are taught Cohen's. The number of reimplants that we have done in the years have been very minimal, if any.
Sir, if you see in this kind of patient, does it give occasionally when we explore this child at this age group, you see the atretic segment, and this segment is not going to go away, I think, with any kind of a double J stenting or any kind of ureterotomy and as well as stenting. I doubt definitely literature like I was doubting at the time of endopylotomy, endopyloplasty. It took away almost 3 to 4 years. Almost all literature for the primary UPGO obstruction and suddenly disappeared, and no one is answering. No one answering that why it is disappeared for the primary UPGO.
No, so what
is it exactly the condition of the literature? Yes, sir. Please go ahead.
No, so what I was going to say was Ram was talking about Cohen. So in a situation with a primary obstructed megaureter, most of us would do like you describe an extravesical reimplant, because if you end up with an obstruction post-op, at least you can stent it from below. So one wouldn't consider doing a Cohen type reimplantation in that setting. That's all I wanted to say.
Right, sir. Right. Margit, quick comment from you for this case. Professor Margit,
yes,
are you there?
We normally use the Lisch-Gregoire procedure, which is also an extravesical procedure. Yes. However, in these cases, you have to resect this plastic segment. And therefore, I mean, I have one slide, but it's a bit back again. So I use a Psoas-Hitch procedure for a couple of reasons, because could you just go back? And
can you see, I have put this slide for you only, this picture. Is it almost similar like that, or it is different? I just go back.
It's different. Go back.
Okay. Where you want?
Yeah, there you see it. So if you go high up, the biggest part or the most dilated part is the lower third. So by doing a Psoas-Hitch procedure, you have a straight urethral pass, and then you can easily adapt the tunnel, also the width of the tunnel, to the diameter of your ureter. And I never ever do tapering. And that's a straightforward procedure. And this is the standard technique we use in a primary obstructive.
So you want to say that you wrap it all around with the detrusor rather than submucosal sort of a tunnel, and that is why you not do. Why you are means suppose if you have a 16 millimeter dilatation, have a fairly good bladder size, still you will risk not to take a tape, not to do taper and having a reflux, because if you look at the literature, the maximum worry in the literature and the failure are mentioned for the persistence means occurrence of the reflux following this procedure.
Yeah, no, if you go high up, then there is a gap in the diameter of the ureter. And because we replace the lower third by hitching the bladder, which is very easy without any bigger mobilization in a child, you really can make a nice tunnel. And you see, this is a megaureter, and you see here a tunnel of 4 centimeters.
Fine. In this particular, it's okay. But suppose if you take, I will show you a couple of other ureters also, if you have gone through my slides. Now, suppose if you have a very much dilated and tortuous ureter, still you will continue with this. We'll discuss that issue also. Perfect. Yes. No problem. I have that kind of a pictures also. Okay. Any other comment for the procedure, Supul?
No, Anil, I agree with what you have done. Only thing I can say is depending on the surgeon's practice and preference, any approach could be used.
intravesical reimplantation or SUASIT reimplantation, or even robotic or laparoscopic reimplantation
Perfect, sir.
be done. But one thing to support Manoj, we know that the majority of megaureters resolve spontaneously without needing any intervention. So there is a place for dilatation to see whether it would resolve as well. You might say, well, there is a narrow segment, but you have a discussion with the physician and say whether they would like a minimal intervention approach of dilatation to see whether that would work. If they say, okay, they would like to go ahead with it.
Sir, my brief point is that suppose people like practicing in my area, or most of the Indians are practicing in almost non-institutional areas where every possible failure counts. So any procedure which is giving me less than 90% outcome, it's very difficult for me to decide.
Anil,
the reason is that it's very difficult for me to explain.
Anil, can I come in here one second?
Yes, Ram. Yes, please.
I have to say, I do not agree with my colleagues in the United Kingdom. And what Supul said a statement, I'm really sorry to challenge that. He said vast majority of patients with vesicouretery junctions are settled with dilatation. That is completely untrue. I'm sorry. Literature, it provides a narrative which is not correct. So vast majority of patients do not settle with that. And that is the reality of the fact. The very small percentage of patients improve with dilatation and stenting alone. And that is why reimplantation is the only approach.
Yeah.
One more point I want to make is as constant this talking about the surgeon's preference. It's not about surgeon's preference. It's about what you do. No, it's about what you do and how you train people. And it's about how you do these things as a patient.
Oh, sorry, someone is disturbing Nitesh. Nitesh, please mute. Yeah, please, Ram, continue.
No, what I want to say is that there is often this talk about surgeon's preference. That is not the right answer, because it's got to be done what is right for the patient and what is important in terms of imparting training. And what you tell is correct, Anil, in the sense that vast majority of procedures that we say cannot just be suited for one surgeon. It's got to be applicable for vast majority of cases in different clinical settings. And therefore, in this case, there is no argument. It's only one option, and that is a proper reimplantation like what you've done. There is no dilatation going to help this patient.
Okay, fine. There won't be end of discussion if I don't go in another case. So this is a case number 2. Again, 5-year female child with history of day and night time incontinence, history of UTI and fever, urine culture, Klebsiella, sensitivity to nitrofurantoin, serum creatine 0.5 milligram percentage, USG, left hydroureteronephrosis, left kidney small, left lower ureter massive dilatation, right normal, bladder normal. Here you have a BCUG, there is no reflux. I agree, maybe at this age this could have been avoided, but I don't know. For any hydroureteronephrosis, my first investigation after sonography is the void in situ ethography to know whether there is a reflux is there or not. Maybe it may not make a difference in this patient's management. And this is the diuretic scan. The relative renal function on the right side is 96.6, and our involved side, that left side, is 3.4%. So yes, Manoj, let us go ahead with you. What is the diagnosis? Any need for further investigations and your treatment plan?
So from your description, it looks like a single system ectopic ureter with a poorly functioning kidney.
Right.
That's what I think it is.
Yes. Yes. And there is incontinence.
Yeah. So, and the history is very important here, where you have said there's persistent day and nighttime wetting, and the child has, never been dry or could not be toilet trained ever. Right. Now, the one thing I would say is that as I said in my comment, doing a VCUG in this age group probably is not necessary. You've done it, that's fine. But I wouldn't do a VCUG.
I might be that, because the reason is that I agree that it won't have made any difference in my management. Maybe. Yeah. Right.
So it's something we find it quite traumatic in this sort of age group.
Agree. My last couple of years journey is to talk about the reducing the number of VCUG whenever it is possible. So I probably agree with you. Yeah.
Can I make a comment about the VCUG? There's a good study done by the group in the Institute of Child Health and Great Ormond Street, So what they said was, if you look at the ultrasound and you got normal looking kidneys, it is very unusual that you have persistent VUR, and most of the time the bladder would be normal. Okay, so that's quite a useful thing to remember. So you've got a normal ultrasound. It is not relevant to this.
Yes,
but
sir, we discussed that area in a first webinar. Sorry for that.
Okay, fine, good.
Yeah.
So here with a very poorly functioning kidney in a single system, what I would offer is a laparoscopic nephrouretrectomy.
Okay. Supul, anything different?
No, it's a laparoscopic nephroureterectomy. It's a day case procedure. The child can go
how far you will go on ureter?
Because there is no reflux and there is no real need to remove the whole ureter, and there is no ureterocele in the bladder, there is no reflux.
So that is exactly reason I still sometimes in my mind, because we had a last year discussion of one of the case of Professor Hemant Pathak, where there was a reflux which was missed in this kind of similar scenario, and that patient came later on with because big stump was kept, some large stump related complications were there, and ultimately they had to go ahead and remove the rest of the things. So that is only.
So, Anil, what I would do is I would do a cystoscopy at the time of the operation.
Okay.
So I can see the ureteric opening, whether there is a wide ureteric opening. If there is a wide ureteric opening, I would do a nephroureterectomy, removing the ureter right down to the bladder. Otherwise, I would just remove the kidney and some of the ureter, which is accessible easily.
Right up to the bladder means you will go how far behind the bladder?
If it is reflux, I need to remove that ureter completely down to the bladder. I don't want to leave.
Maybe yes, there is incontinence. Maybe it is at bladder neck. You will go right up to the bladder neck.
See, as I said, I would do a cystoscopy.
Maybe it is opening in the vagina. I don't know. But
yeah.
Anil,
as I said, I would do a cystoscopy at the beginning.
Okay.
So I would remove this ureter only if there is a wide opening inside the bladder.
Okay.
If I don't see a wide opening, just removing a little bit of ureter and keeping the low end open so that it will just decompress by itself is the treatment of choice. Child will go home in a few hours, and that is the end of the management.
Okay, perfectly. All I agree. Ram, any difference?
I'd like to comment. I mean,
yeah, I'm coming to you, Margit. Yeah. Ram, you finished.
Just
I'm not so sure.
A short comment.
Yeah,
if the child is incontinent, the opening must be below the sphincter. So, and therefore there cannot be a reflux, because otherwise the child would not be incontinent.
Okay, agree. Perfect. Yeah. Okay, right. Yeah, good comments.
I actually agree with Margit, because in all these ectopic ureters, yes, there can be reflux in ectopic ureter, but that risk is extremely small. Extremely small.
Yeah. So we can avoid
you can
VCUG,
just
maybe.
you can take the ureter as low as possible and forget about it, and nothing is going to happen.
Okay, so you go ahead with the laparoscopic nephrourectomy as low as possible ureteric removal.
Yeah, I'll do robotically. Okay, perfect. And Margit,
you? I'll go to your slide little later, but how you will manage this case?
No problem. Whatever you can do. So we would do it laparoscopically. We have the robot, but we don't use it in kids.
Okay, perfect. I think Dr. Ansari and Hemant Pathak, both of you are agree with the same management?
Yes, agreed.
Perfect. So I was just going through the literature, and what I noticed in literature is that something like a clipping, laparoscopically go clip and divide. I again wonder here that why it is so. And anybody want to speak about it for a minute?
Yeah,
Manoj?
So yeah, that is done only for a duplex system with an ectopic ureter from the upper pole. So see, the group from Toronto popularized that. We have done it in duplex systems. So what you do is do a cystoscopy, put a sort of a ureteric catheter in the lower pole ureter to identify that.
So this is your comment, yeah.
Yes, and then you do a laparoscopic ligation and division of the ureter. Now that is an option for an ectopic ureter in a duplex system in a girl.
Okay, perfect. So we almost all agree, and we had a very good discussion on voiding cystoscopy. Maybe I would have skipped that investigation. So coming to the third case, that is a 24-month male child, recurrent febrile illness, was treated with antibiotics for a couple of times. Mind that it's a recurrent febrile illness, and that time he was never investigated for the presence of urinary tract infection. And failure to thrive, underweight, height, On last febrile illness, UTI was confirmed. Culture was positive for E. coli, treated by pediatrician with iron, third generation cephalosporin, serum creatinine 0.5 milligram, 0.51 milligram percentage. USG, you can read this. There was right kidney gross hydronephrosis, hydroureter up to the junction with cortical thickness of 2 to 3 millimeter, and lower ureter was massively dilated. Left kidney shows mild hydronephrosis with the moderate sort of hydroureter up to the junction, and no evidence of solid or cystic mass, and bladder was normal. Kidney size is not mentioned in that sonography. And this is the voiding cystography. I'm sorry for that, but this is the quality of VCUG. I received this all investigation. These patients came to me with all these investigations, but I could see here this kind of a reflux. So, and I don't want it to repeat this voiding cystography. So this is the picture of MCU where you can see that there is a massive reflux is there, but the contrast is not still reaching up to the kidney. And this was the DMSS scan. Now, I received a comment from the Manoj that exact timing, but the timing is that, as I said, that there were recurrent febrile episodes, right? So it's very difficult to say when was the exactly first infection and how many days or how many months after this scan is done. But this is the DMSS scan. And Professor Ram, I would like to request you to read these lesions, because we have a previous webinar, extensive discussion on the describing the various lesions seen in the DMSS scan in patients associated with the reflux. But here, in this particular patients, you have a DMSS scan, and please take forward from here your observation on the DMSS scan.
So the DMSS scan is a lovely, beautiful scan. It's a shame that the MCUG was not satisfactory to demonstrate the extent of reflux, but clearly there's a dilated ureter behind and below, and then I'm sure when it goes up, it is a fairly significant reflux. So yeah. If you go back to the DMSA scan, Anil, this is a nice bean-shaped kidney on the opposite side, and on the other side, you can see there's significant scarring, and there is rarefactions with multiple photopenic defects across the entire kidney. The architecture is pretty much compromised. So this is
and you have a cold area, photopenic areas also on the left side also. At
yes,
the polar
also,
region.
Well, there is some on the left, but yeah, there's one here in the lower pole. There's one here, but this also. Side is far more lovely, beautifully shown.
Yeah.
It's a shame the MCUG did not pick up things properly. We could have known a bit more about what is causing it, but that's what it is. Yeah.
Okay, perfect. So there are definite evidence of pyelonephritis, recurrent pyelonephritis, and related changes, right? So here, if there is a loss of contour, we will not hesitate using the term scar. If there is no loss of contour, we would have still continued with the multiple photopenic areas. But on left side, there is a definite loss of contour, so we can quantify explaining this lesion as a scar. Now, this patient again came from the other center, higher center, with this CT scan. And we have discussed a lot about the need of CT scan or avoiding CT scan, but here we have, you can see here, there is a severe, massive dilatation on the right side. Left side is also significantly dilated system. And there you can see on other CT pictures, the cortical conditions. This is the report, but you all, I'm not going to read detail this report because all these pictures you can very well pick up all findings. So Manoj, let us start with you, the diagnosis.
So
do we have now enough of investigations to put a diagnosis? For example, I took a diagnosis of a right probably a obstructed megaureter, and left maybe a refluxing, obstructing megaureter or refluxing megaureter.
Okay, so
this was my interpretation at that time. Yeah.
So basically, from all the imaging you have showed, you have clearly documented that's grade 4 VUR on the left-hand side. So we know that. Yeah. It's probably there's an element. If you had a delayed image on that MCUG, it would have shown whether it drains properly or not.
Perfect. Perfect.
Or obstructive refluxing. On this CT IV that you have done, it shows probably an obstructed megaureter. So basically, you got an obstructed megaureter on the right-hand side and probably an obstructive refluxing megaureter on the left-hand side. And this is a child with recurrent symptomatic febrile UTIs, from what you have said.
So Margit, coming to you, now you look at this condition of ureter in the CT picture, right? It is massive tortuous dilated ureter. I will show you the even operative picture. Still, you will go ahead here with the, suppose if you go ahead with the reimplantation, you will not taper this ureter?
Yes.
Okay. So
I
what
haven't
exactly you will,
tapered a
you will
mega
remove?
ureter during-
How much lower ureter you will sacrifice or will take out?
If you do a hitch,
So
you can
in this case,
at
suppose
least,
if you take out, see, it is, if you see the dilatation is a bit different in compared to
No.
other cases. The dilatation is increasing, you go up and up. Yeah.
But if you go up, you have these curves of the megaureter, and when you free up the megaureter until the pyloureteric junction, you get a huge long megaureter. And I normally resect 2/3 of the megaureter, and there is a gap in the diameter. So the first 1/3 of the megaureter is always much smaller.
I
than the
personally
rest of
fear,
it.
Margaret, I personally fear to dissect whenever I plan reimplantation, tapering with reimplantation or simple reimplantation. I just dissect almost 7-8 centimeter, in almost all cases, and I have not seen any problem. And in post-operative pictures, all these tortuosity disappear over time, and they start looking very well. I will give you the follow-up with this patient.
Okay.
But yeah, okay, perfect. So coming to Ansari sir, you are silent since long. What would it be? What surgical approach you would have chosen? What surgery and approach?
So the approach which I'm telling may not be pleasant to many, because
Okay.
you know, I have been doing most of the reimplantation, even if it is a megaureter, whether refluxing or non-refluxing or both, it transvasically. I
Agnes, sir.
rarely go. Yeah,
No
I
problem.
rarely go outside, because doing so many laparoscopic transvasical also, even if it requires any tailoring, there are criteria when to do tailoring, but I hardly go, even if it is unilateral or especially in bilateral, I never go outside. Even unilateral, I prefer to do it transvasically. Everything is possible to do to, even
the
tailoring, yes, can be done.
Okay. First, the approach I chose in this patient, that I did extravesical dissection on right side, and then I tapered, and then I opened the bladder and reimplanted intravesical, and did left side procedure completely intravesical. So this is just to tell about my, and Ram.
Yeah. So Ansari, I want to give this fascinating story is that I trained doing intravesical. I learned Cohen's reimplantation. I came to the UK. That's what I did for many long years.
Yes.
And believe me, it is when I started doing robotically, and I started finding that you can go to the vesicoureteric junction very easily. And then my whole concept changed about reimplantations. Now, even in those odd cases, I have to do open. I do all extravesical. And it's just fascinating how much you can actually do extravesical and not go into the bladder mucosa at all. And my personal belief is that if you don't enter into the bladder, I think the bladder functionality is much more sacrosanct and kept safe.
So you would have done both the sides are extravesical?
I dare, if I may, Margit, please, I can dare to disagree with you. I do not excise that much of ureter. I would be doing, managing it with the as distal end as possible and leaving the ureters in the top, because once the procedure is done, the dilatation settles down quite nicely.
So Ram, I am very lucky that I have a friend in you.
Oh, absolutely. You have. You impressed me with your surgery there.
No, it's okay. But you tell me that you will be doing both the side together and both extravesical completely?
Yes. So now when I'm doing I do a lot robotically now. I do bilateral.
Coming to this patient, you would have taken this patient robotically?
Bilateral extravesical reimplantation, no problems. Yeah,
okay.
Absolutely. Yeah.
So you would have taken this case, and you would have preferred doing tapering at least on the right side?
Well, that depends. Again, I told you I don't want to comment on tapering till I am on site. When I am on site,
I will give you the on-table picture. Yeah.
Upon the detrusrotomy I'm able to create a good wrap.
Okay, perfect. Hemant Pathak, sir.
Yeah, I think I'll do one reimplantation.
Yeah,
because the dilatation is quite significant. Yes. I would definitely prefer tailoring. on both the sides. And yeah, I prefer Cohen's, but in this case, I will do combined extra and intravesical, tailor the ureter, and do a good reimplantation.
Yeah. Manoj?
Yeah, so I would agree with Ram on this, not robotically though. So extravesical dissection as much as possible. And again, I wouldn't do a Cohen for the simple reason that probably something like a Politano lead better. So that so there have been situations, especially with refluxing obstructive, if you end up with an obstruction, you need some access to the ureter from the bottom end. So that's what I would do. I wouldn't do a Cohen personally.
I tend to agree. Since last 2-3 years, I drifted from Cohen's to the Politano lead better sort of thing, because I'm living in the stone belt, and off late I started getting the patients with the Cohen's where there is a urolithiasis and there is a difficulty in intervening. But in era of flexible ureteroscopy, I think flexible scope. Manoj, there was a question from Ansari, Professor Ansari, in a couple of weeks before when we were discussing on a USI platform with Rama Jayanti. Because Rama is very much ardent follower of Cohen's and Ansari also. So there were a lot of debate about the problems with the Politano lead better, because that found to be a difficult procedure, purely Politano lead better. So would you like to have some comment on this?
Yeah, so firstly, the first thing to say is that the number of reimplants that we would do for VUR are very minimal in the UK. My colleagues may beg to differ, but I'm sure they would concur on that, because with the advent of endoscopic correction. The second is number of VUJ holdups that you end up operating for are very minimal. So most of the
but sir, coming to this case,
so
this sort of cases here,
I would personally do a Politano lead better. That's what I would.
Perfect. And you will do completely means extravesical dissection, adding the intravesical, or purely intravesical, like Dr. Ansari?
No. I would go completely extravesical, and I would not dissect, as Margit said. I wouldn't dissect all the way up to because I would be worried about devascularizing the ureter.
So Margit's that comment is no one is going to buy. I think almost from 6-7 people. Yeah. Yes,
I'll just share our experience.
Yeah.
As far as the laparoscopic extravesical, when the ureter is of a normal caliber, results have been excellent. But when the ureter is dilated ureter, we have followed them up with a VCUEG after 4 months or 6 months, just out of academic interest. And there has been about 50% of them having reflux. So after seeing these results, I have, again deviated myself from.
Okay.
So
especially dilated.
Okay, Margit, you deserve a comment. Yeah.
Eamon,
if
a ureter is normal caliber, you shouldn't be operating on them.
No,
I'm pathology. There is no pathology.
You're misunderstanding. If VCUG shows a grade 3, grade 4 reflux, so many times we see that the ureter is not grossly dilated. You don't say it as normal caliber. What I mean is, the ureters which we are seeing just now on the CT-IV, those type of ureters, we are not going to do well.
I agree on that concerning reflux, because we worked up our Liège-Grégoire, which is my standard technique for reflux, and it's very good in the non-dilated ureters. As soon as they are dilated, then the results are worse. And therefore, we switched in the very dilated, and I mean in the primary obstructive megaureters, you have to resect the lower part. So we switched to the Psoas-Hitch technique. In a long run, we had a success rate of 97%, which is really comparable to
the Margit, the problem with you is that suppose if you have bilateral condition, you select to operate one by one. That is very difficult to buy, and that is very difficult to agree, because we do in and out bilateral procedures without having any problem. Intravesical, intravesical together, or at times both side extravesical without. And I just see is there is any innervation difference or any problem with this pediatric age group bladder in compared to the patients coming at elderly age with the VVF, where we dissect completely posteriorly the bladder to detach it from the vagina, and then we repair it, and to our surprise they start voiding comfortably on a first catheter removal. That is generally we do it by the end of 2 weeks. So why there is too much of fear of not doing bilateral extravesical? Is it
you
really?
Can do it. You can do it, but you have to respect the nerves. There are some nice studies showing where the nerves are going in, and if you stick close to the ureter and don't do much of mobilization around, then it's fine. You can do it.
Okay,
There are
perfect.
some
Can
data.
I
Ram,
make
you
a
wanted to
comment
make
on
some
that?
comment, Ram.
Anil,
Yeah.
Anil, you're very brave disagreeing with Margit.
No. she is a friend, and this actually, Ram, to be frank,
She's my
with you,
friend as well.
no, this
She's
is
my
this,
friend as well.
This exactly, Ram. This exactly started with the webinars with the Margit. This is a third and last webinar series with the Margit. She promised me at the Goa when we meet at the first week or second week of March in semi-live.
Anil,
Yeah, please.
Anil, now the images which you are showing now on the
Yeah.
screen, in such a situation, I don't think we can go away without tailoring. No?
Yes, perfect.
These ureters are going to need tailoring.
Yeah,
irrespective of
I
whatever
cannot
approach.
imagine replanting this ureter without tailoring.
So, but Hemant, why can't you do a tailoring extravesical? I don't understand that.
It
Why
can
can't
be.
you?
That is
I'm
what
not
exactly
saying
I do.
extra or intravesical. You know, not tailoring. I'm saying that tailoring will be required.
But
So
what
this
I'm
is-
trying to say,
These
what
are
I'm
the
trying
couple
to
of
say is
pictures,
that
Ram.
you
These
must
are the couple of
reserve-
pictures on table. There you can see that there are narrow adynamic segment, and above that you see the dilatation. So on detaching, definitely that will definitely regress. But here you can also imagine that it won't regress to the extent that you can have that proper tunneling, proper amount of ratio of tunnel with the width. without
Anil,
tapering.
can I
Yeah.
make a comment?
Anil,
Yes,
Anil
yes.
and Hemant, what I'm trying to say, I'm trying to articulate that there is no evidence, no guidelines to suggest that you
Have
need
you
to
followed up with VCUG in all your implantations?
Hemant, one
Coming,
minute. What I'm trying to
Hemant
say
sir, coming to
is
that point.
that
Yeah,
the
let Ram
decision-
finish. Yeah,
the decision to taper should be on table.
absolutely. So I have given
All I'm
you
trying
one
to
table
say,
picture.
no,
Yeah.
all I'm trying to say is pointless deciding on imaging that I am going to taper.
Yeah,
Or
agree,
if you
agree.
have to taper, please do so.
So
But there
go
are
ahead, agree. No
there are
disagreement.
occasions when the bladder is big enough, you can accommodate a dilated ureter without tapering.
Yeah, if you
all
get
I'm
a
trying
good
to say.
tunnel, and if you have a 12 millimeter, but you are getting 7 centimeter tunnel, you can go ahead. Agree, right? So, but in this kind of a situation, I think you are agree. Are you agree with the tapering?
Oh, yes, yes, yes.
Yeah. So here it is still not detached. So I absolutely agree with your comment that only we can decide after detaching from the obstructed segment, and then we have to take a call. Depends on the caliber of the ureter as well as the condition of the bladder, size of the
Dr.
bladder.
Anil, so
Yeah.
Dr. Supul want to make a comment.
Yes, Dr. Supul, yes, please.
Anil, I was bit
Sir, sorry, suppose if I don't come, you can jump in. Yeah, please.
because no, I thought it is not fair to jump in. I
No,
thought
no, please, sir.
you were the coordinator. And
No,
then
no, no, sir. So because see, the virtual meeting
people sort of
limitation is that
equal amount
till
of
you
time
don't raise your
to
hand or don't raise your voice, you won't be taken into this. I will try to come in a rotating fashion. Yeah, please.
please do, right?
Yeah.
Because you need to give time for me to make some friends as well.
Yes,
right?
sir. Please, please.
Everybody is making friends, so I
Okay.
need to make some friends.
Yes,
so
yes, sir. Please go ahead. That humor we wanted. Yeah, please.
I tend to agree with Manoj.
Yeah.
So I'm Manoj friends about we don't do very many operations for refluxing ureters.
Sir,
nice-
agree. That is
with,
agree,
nice
sir.
dilated ureters.
That is a trend. That is a trend also in India that we are really that we have discussed already. You check with the Margit. We excellently discussed that we have a really very limited indications for reimplantation in the reflux. So that we have discussed. Yeah, please.
But I think everybody is giving the important salient points. So I need to make friends with Margit as well.
Okay.
Margit discuss about being careful about the nerve supply.
So Margit, you have to stay for another 15 minutes more. Yeah, please.
Yeah. So
Go
it is very important to stay really close on the ureteric wall itself. And then there are patients who have had bilateral extravesical surgery, who have had neuropathic kind of bladders due to the amount of the surgery and dissection and damage to the nerves. So that is a very important thing. Nobody should forget it. So got to stick very close to the wall. And then if there is a tortuous ureter, I think I'm your friend as well. You need to remove the narrow segment, but you also need to remove some of the dilated segment as well, because there is a tortuosity dilatation, and then you need to taper and narrow it down.
Sir, generally I remove 2 to 3 centimeter, just a distal most part, which is go with the obstructed part, and then 5 to 7 centimeter of tunneling with the tapered or non-tapered. And to my surprise, in almost all follow-up cases, there is a definite regression of or disappearance of tortuosity and regression of dilatation without moving much higher. In my initial practice, I was going up to 10 to 12, 15 centimeter, but I stopped doing that at least, and that I'm giving honest follow-up of long term. Yes,
that's
sir,
correct.
please.
Yeah. So the important thing people got to take home is when you do the reimplantation, not to narrow it too much.
Yes,
If
sir.
you create obstruction as you are doing a reimplant.
So how exactly, sir, you do tapering?
So
You
before
do in a 2 layer, or you do in a single layer, you pick a continuous stitches, intermittent stitches, what exactly suture material you use, and how much big segment you taper? Yeah.
Steps are, I put a tube into the ureter and tie the end. I
Right.
dilate, I stretch the ureter by filling it with saline, and then I mark on the ureter with the pen on the serosal side what part of the ureter that I am keeping, and then I remove that excess ureter very carefully, and then I do a 2-layer continuous suturing to close that up, and then most of that
2 layer means first layer of what and second layer of what?
Anything should be fine. White
No,
would be
no, sir. Well, first layer, what tissue you include, and in second layer, what?
I generally use PDS, 6O PDS.
No, sir. In a first layer, what you exactly approximate? In second layer, what exactly you? Because the reason is that I do in only in a single layer. So I would like to know what exactly constitute the first layer and what exactly the second layer.
The first layer is a continuous of the whole wall, right?
Whole wall, okay.
Wall of it, and the second layer would be few interrupter sutures to make sure that the first layer doesn't got any tension, right? So, and then I will use the narrowed segment for the reimplantation. And as long as you don't make it too narrow, you can expect resolution of the dilatation. And I want to become Dr. Ansari's friend as well. Intravesical approach, mobilizing the ureters is perfectly reasonable. If you can keep, you can stay close to the seros of the ureters and do a good dissection. Now I want to become Ram's friend as well. Intravesical approach, the main problem is this bleeding. So once you do the operation, you got to make sure that the mucosa is closed very nicely, beautifully, and there are no raw areas in the bladder. And then use a suprapubic catheter for a few days so that there is no blood clots to cause problems, and then everything would heal nicely. Thank you.
So very much I agree with your all this information, except I was very much good fan of suprapubic whenever I do intravesical, but over a time my friend taught me that you are doing too much because you trust on the surgical skill, which is improved over a time, and then went away from the keeping that extra suprapubic, the fear of a little bit of bleeding and clotting and clogging. But maybe we'll not divert the discussion on that. I think, Margit, you are not doing tapering, so I will not bring you in this discussion. Manoj, you want to say last word? Yeah. Please.
Yeah. So just a word of caution, as Margit and Supul have pointed out, I've seen few patients, both in London and in Nottingham, who have ended up in retention, having had bilateral extravesical dissection. So as was said, I think it's important to keep that in mind.
Perfect, sir. But sir, in your practice, you have ever done bilateral together and end up with this retention, prolonged retention?
Yes.
Okay. Ram, have you done bilateral together, extravesical, and end up with the retention prolonged?
No, I have not. I have not come across.
Yeah,
I have not come across patients.
Who want to make a comment?
Yes, I do. I want to make 2 comments. First comment is that the bilateral, there's too much of paranoia about bilateral reimplantations. I agree with Supul and Margit that if you dissect too close to the bladder and then you're messing around that area without in the right planes, then you can cause damage. I agree with that. But if you stick into the right principles of the anatomy, then you're unlikely to cause that thing.
Yes,
in terms of tapering, I do excisional tapering and I close in single layer, but I invert the mucosa. So I actually do like those Lambert sutures like you do in the intestinal anastomosis. So I bring it outside and I go, from outside, I pick up the serosal layers and I invert it that way.
So it is intermittent. Intermittent. Yeah, perfectly. So again, I have a friend in you.
Anil, what is important also is that the way you do tapering depends upon how you align it in the bladder. So when you do an extravesical and you create a detusrotomy, the tapered segment must, or the suture line must lie against the mucosa.
Mucosa. Perfect.
Correct.
Yeah.
That's it. And
Yeah.
there is no big deal. And the
No
last,
big deal.
last
No big
funny
deal.
thing I want to say is, Supul, you don't need to make friends with everybody, but with pathology and anatomy. If you're friends with a pathology, you'll be a good surgeon. Forget about making friends with people, because the patients will be beneficial to you.
Okay, so this is the follow-up of this patient. This is a 6 month post-operative sonography. Unfortunately, we don't have a sonography prior to the surgery to compare, but we have a CT scan picture there. You can see the amount of dilatation. This is a single plate IVP was done at the 6 month, just to look at the what about the system looks like. And this is the recent, just before 3-4 days. Again, patient was invited for this purpose, and this is 24 months post-operative picture. We can see there is definite a good amount of cortex. There is a significant reduction in the dilatation. Some dilatation is going to be remain there, and both the side. And patient is doing perfectly well. Creatinine is normal, not developing any febrile UTI. He is on antibiotic prophylaxis for 3 to 4 months, and thereafter he is right now not on any of these antibiotic prophylaxis. But still, last word of a caution here, Manoj, from you. These patients still can have a worsening of a renal function with the increasing age, and how that exactly you will communicate with the relative or parents.
So
Do you agree that there is some fear that with the increasing age, this child kidney could not cope up with this demand, and can have some symptoms appearing of renal failure? Yeah, please.
Yeah. So one of the things all of us need to remember is the greatest enemy of good results is long-term follow-up. Just following patients up for 6 months or 12 months is probably not necessary.
No,
long term.
absolutely agree. That's a perfect
Yeah.
comment.
So,
Yeah.
Yeah.
We
so
have
it
to
is
till
important-
go at least go up to the adolescence. Yeah.
Yeah. So you need to follow these children up carefully. Ultrasound, yes, you can do ultrasounds and monitor, because the dilatation may not change a lot over the course of the time. So simple things like urine test for proteinuria and such like are important. So also is annual blood pressure check. So those are simple things that you can monitor.
Perfect. Agree. We do
you
it.
need to monitor renal function long term. So in these patients who have start off with in cricketing terms, behind the stumps with a sort of impaired GFR or high creatinine, they need to be followed up with nephrology as well.
Okay, perfect. And Miss, suppose when you plan to operate, you have still in the back of your mind that you can successfully operate, but this kidney could not improve to the extent that over a time patient can cope up with this increasing body muscle mass. How do you think that this is a real fear, and how exactly you will communicate with the parents?
Yeah, so it is important to have that discussion at the outset. So what you can do is you can improve the appearances and stabilize the function as best as you can. And as you very correctly pointed out, come onset of puberty with the increasing demands, you may just push the patients over the edge. So somebody who's in having mild renal impairment, you may push them towards moderate or severe renal impairment. So I think the early discussions need to be jointly with nephrology as well. So that's the way we do it here, and I think that's what one should do.
So this is a fourth case. This is 2-month female child, febrile UTI with antenatal HUN detected.
Anil,
Yes.
Sorry to interrupt you. I have to leave because
No,
I have
you have still 20 minutes. You are there up to another 20 minutes, and your slides are coming. So please be there for 20 minutes. That's why I jumped to this case. So this is 50 days old female child. I'm not going to go through the whole list of the history. Fever since 3 days, crying while micturition, febrile UTI, recurrent examination, nothing specific, left HUN, urine analysis recurrently showing the pus cells as well as culture positive, initially E. coli, no growth after the antibiotics, and serum creatinine was somewhere around the 0.34 milligram percentage. So it's a 2-month female child presenting with the 2 or 3 episodes of febrile urinary tract infection. And there was a knowledge of antenatal HUN, but there was no knowledge of anything more than that in antenatal sonography. So this is a postnatal sonography. Here you can see upper pole and lower pole on the renal side, renal level, and at the bladder level you can see some cystic sort of structure, thin membrane structure. This is with the ureterocele, and then of course done VCOG at that particular time, and you can see that there is a reflux into the lower moiety on the upsilateral side, and there is some reflux on the opposite side also. And then This is the thing. So this is the diagnosis with the febrile UTI, excessive crying while micturition. And Ram, what will be your response to this patient? How will you treat? Hello.
Yeah, sorry. Yeah, can you just go back one slide for me? Yeah, okay. So yeah, I get that now. Do you have a DMSA?
No DMSA at this juncture. Do you think that this is a good point, valid point? Would you like to have a DMSA at this particular juncture?
100%. 100% for all patients with a duplex system. I would have a DMSA baseline for me before I do anything on these.
Perfect. Now, why I didn't send this patient for that? Unfortunately, again, this patient came from another center with the CT scan and all those many radiology involving investigations, and I still take it a point that definitely will consider for further practice, and we do practice. Okay.
No, that is fine.
Yeah, please.
That's fine. The important thing is that this is a fascinating situation here for future discussion on our as we go along. Is if you have ipsilateral or contralateral reflux in a duplex system, then the whole situation changes in terms of management of ureterocele.
Now here she is only 50 days. And she is having a febrile UTI with these.
But she's what I'm trying to say. She's got bilateral reflux.
Yes,
both in the ipsilateral as well as the contralateral side. So ipsilateral lower pole and contralateral with ureterocele. The evidence clearly says that in these patients, if you treat the ureterocele alone with a puncture or whatever you want to do, you will vast majority, 80-90%, you will come back for bladder reconstructive surgery or some other kind of surgery. DMSA is important because you need to know what the upper pole function is corresponding to that ureterocele, so that you have options what you want to do. So if there is no function, then you can go either of an upper pole eminephroureterectomy. But in this
Ram, let me interrupt you. This child is a Sikh, came again and again with the febrile UTI. Would you like to tie up with the right now situation, or you will be right at this particular time, only you will think about delivering the definite treatment?
No. In this, okay, I didn't get that. In the situation of an acute situation when you are in like this, it depends if the ureterocele is teamed with pus and looking like a very enraged abscess or whatever. If the child is not settling with conservative management, then there might be an indication to puncture the ureterocele.
So this is what exactly it is. They try with the antibiotics and all those things. The child was not responding and came third time again with the same consultant. And
no, but that depends. No, coming 3 times is different, Anil. The point is, what I'm trying to say is that if you have recurrent infections in the correct antibiotic, vast majority of these patients also should be managed conservatively till they get settled down and come back to a situation where you can do some definitive surgery.
Okay.
My indications for puncture would be if a child is not settling despite antibiotics and you have to keep in the hospital.
This patient you will consider for the puncture?
If the child's temperature doesn't settle with antibiotics.
Yeah, that was a really case.
Okay, if that's the case, then I would consider, yes, only in those indications.
So briefly tell us that how exactly you do a single puncture, incision, or multiple puncture, like you can say water canning.
Well, I prefer to use like a Bugbee electrode. So I go inside and I buzz at multiple punctures, because you need to have a good drainage, right?
So your focus is not to worry about the future reflux, but your purpose is to decompress as much as, not to take patient again because of failure in a drainage. Because many of the time I've seen people do small single puncture and then they think that it won't end up with this upper mobility reflux. But the purpose is lost. Purpose is here is the obstructing voiding and the sepsis.
No, it's okay. My point I'm trying to say is that my indication.
I agree with the multiple puncture.
No, endoscopic puncture is a part of resuscitation to get the child safely out of the sepsis.
Yeah.
That's my only indication.
Yes, perfect.
I'm not worried about reflux. I'm not worried about reflux because reflux coexists already here.
Okay, so that was a message. I absolutely agree. Manoj, you want to make a point on this? Manoj, your method of putting incision.
Yeah,
or puncture.
Cystoscopy and puncture using a Bugbee in about 3 or 4 sites. That's what I would do. The other important thing, just a comment on what Ram said earlier, DMSA is necessary, but I wouldn't do DMSA very early. You normally wait for about 3 months because the kidney is still maturing. So unless there's an absolute indication, I wouldn't do a DMSA early. I would wait for at least 3 months before doing a DMSA.
Okay, Supul, anything to want to add?
Hello.
Yeah.
No, actually, no. I mean, you have mentioned everything. Just the puncture has long-term issues. So you need to follow these patients up. You would do a puncture in the acute stage, depending on whatever your practice. But
so you puncture multiple or incision? Yeah.
You got to do adequate puncture rather than just a very minor puncture. So you need to get a drainage. And actually, if the child is really septic and there's a lot of debris, I actually inform my radiologist, because if I fail to get the pus drain properly, I would even ask the radiologist to put a nephrostomy as well at the same time to really make sure that the child's kidney is decompressed and that the kidney doesn't get damaged, right? So subsequently, as you mentioned, there is a high chance of reflux, high chance of...
so coming to that point, but right now for acute management, you agree that you will do a cystoscopy and puncturing.
Yeah.
Professor Ansari, you want to make any point on regarding the puncture or incision? Your preference is incision or puncture?
See, this has both the things. A puncture with an intent to create an incision, that makes it optimum. When you make a puncture, whatever scope you are using, it should walk easily through it. That shows the adequacy. I do not know whether multiple punctures or water can procedure actually gives any extra security for re-stenosis. Giving small multiple punctures, they are more prone to get blocked.
So my preference is incision, and I agree that I should be able to walk in without any difficulty. I agree.
Yes.
Hemant sir, you want to make any point? Then I go for a second scenario on this. Hemant sir.
No, I agree with Ansari. Do an incision and have a wide drainage. That's
right. So Margit, would you like to run this slide? Yeah, please.
Yeah, I would agree with Ram. In this case, the drainage is of importance, and it doesn't matter what you do. So normally I do a transverse incision. So this slide is just, again, for those who are on training, because we are discussing as experts, just to remind you that that's the pathology of the duplex system. That means the upper moiety normally is connected with either a ureterocele, as you can see here on this side, or an ectopic ureter, whereas the lower part always has a shorter tunnel inside the bladder and therefore a reflux. Can you forward? And I agree with what was said also with Ram. I normally also would like to have a DMSA. If it's a younger child, a MAC3, then of course the VCUG. And can you just put forward once? No, forward. Yeah, that's the ultrasound we have seen. Forward. And yeah, that's and yes, that's a dropping lily. And forward. And we found the MRI very good, especially in those patients where you don't have really severe dilatation of the upper tract. And sometimes it's really tricky to discover that, especially during ultrasound or even also during DMSA. And of course, it was also mentioned already, when we are looking for an ectopic orifice, then sometimes endoscopy also is of value.
Now, unfortunately, in this patient, again, the CT scan was done already when patient came to me. And there you can see various kind of these all pictures, all the things are available about both the moiety and the exact position of the ureterocele. Manoj, do you think it makes any difference, any sense, means it is extravesical, intravesical, a kind of a Churchill's classification of a system that single system reflux means you can say lower moiety, ipsilateral, upper moiety, both the reflux, and third is the opposite moiety is also, opposite kidney is refluxing. Does all these things to recognize and realize prior to the procedure and explaining all those things are required, or doesn't make much difference in when you can see this kind of situation? Yes, please go ahead.
So the first thing is duplex system ureterocele generally by definition are ectopic because they straddle the bladder neck. Single system ureteroceles, as we see in the adult age group, most of them are orthotopic or intravesical. So the management of puncture actually came from adult practice where an orthotopic ureterocele was punctured, and generally they would have reasonably good function. Whereas the duplex system ureteroceles, where the upper pole is subtending the ureter has generally very poor function. So that's what I would say.
Okay.
So it doesn't matter whether it's an ectopic ureter or an orthotopic, but we normally don't see orthotopic ureter in duplex systems.
So I agree that my preference is incision, but it can be a multiple puncture. But as per the literature, there is almost chances of having a 50% chances of upper moiety reflux in this kind of a configuration. I don't have a very large experience on this kind of a cases. So Margaret, you go ahead with the couple of 2-3 slides for the trainees purpose. Yeah, please.
Yeah, we just discussed it. I mean, you either can do a transversal incision or you can do puncture, single or multi-puncture. And this is only indicated if in an acute intervention. And because Ram already discussed it, that you have a high rate of secondary interventions, which is really ranging from 18 to 47%. Forward, please. And for the ectopic ureteroceles and the big ones, really, it goes up to 100%. That is what we already discussed. This is just a summary.
Okay. So the thing is that when you will take this patient for the further investigations, Margaret, you have put an incision, patient is doing, or multiple puncture, patient is doing very well, growing well on antibiotic prophylaxis. When you will take again this patient for further investigation? Hello. Again, Nitesh, mute everyone, Nitesh, please mute everyone. And now open the Margaret Fish. Yeah, please. Unmute Margaret Fish, please.
Okay.
Yeah.
So, I mean, when the child has recovered, I would do the rest of the diagnosis, what have not yet been done. That means a DMSA. Okay. And also, what I also mentioned, maybe VCUG. An MRI.
You will do VCUG also, no?
There is no need to rush, as Ram said. I mean, you have reflux on both sides. Now, maybe you have a refluxing upper tract. Okay. So you can continue on a conservative way, putting the child just under antibiotic prophylaxis.
Perfect.
And what happens?
Perfect. And at what age? There is no need to rush, but at what is your preference? What age you will take the child for the further investigations?
No, I don't understand. I mean, I would do the diagnosis.
See, this child is operated at 3 months and doing well up to 1.5 or 2 years. You will continue with following just conservatively without adding any more investigations other than the sonography. And yeah, so that is, I think we have to discuss, that is also one of the way of following this patient, that they may not require anything to do in a significant number of patients. So why to add radiological or invasive investigations? You agree? Or no, you are 100% sure that
absolutely. If the child is asymptomatic, just do ultrasound control and nothing else, and don't touch the child.
So I have a couple of cases experience where I have done because of voiding difficulty or because of sepsis, this kind of surgery, and at least 3 female patients, they didn't require anything out of my double-digit number patients. So Manoj, you would like to add any more comment here?
No, it's just that, you follow the children up with ultrasound scan. I wouldn't do any invasive tests. So long as the child is asymptomatic, thriving, you can just follow the child up expectantly.
Okay. And if you have not done the DMSA, you can add the DMSA just to have an idea about the function. Okay.
I would certainly do a DMSA but just after 3 months of age, not before.
Okay, perfect. So Supul, you want to add anything? You differ?
No, following puncture, as you mentioned, you manage conservatively and you do the investigations to get an idea as to what is happening with the function and everything. And you would only take action if there are symptoms.
Yeah. So and that's a big message we wanted to pass. And I think we all have a consensus. Ram, do you agree, or you will do investigations even this patient is doing perfectly well?
No, but once I have all the investigations which I have mentioned and the child is out of the septic situation, and I as I said to you, I will always do a DMSA scan in a planned fashion. Nobody does it in an acute phase. I will proceed for surgery safely if I can take the child around 15 to 18 months of age. When it's a good weight, then I would go ahead and I would do a bladder reconstructive surgery. of excision of the ureterocele and
suppose the child is doing perfectly well and there is no UTI, no obstructive voiding, and child is growing without any problem, and you taken the child off of the antibiotic prophylaxis, and still you would like to do VCUG to know the reflux is there or not.
So we have just published, Anil, we just published in JP Urol, and the results are coming out just now.
Okay.
The fact is that if the child has got ipsilateral or contralateral reflux in these circumstances, almost always, nearly 80-90% of them come on for some kind of surgery later on in the bladder level.
Okay.
And that is the reason why I would electively, when the child is well at about 15 to 18 months, proceed with ureterocele excision and reimplantation. That's my preferred option. And I'm just sending a chat to everybody that if you want to see a 6-minute video at the end, I can share my screen and show you of how the safe ureteral excision is done. Okay.
Okay. Perfect. We'll take that chance. Okay. Yeah. Okay. So I think Professor Ansari, I move with the next case. This is probably last case we can take. So this is a 11-month female child. This will probably cover the almost all scenario related to the duplex. And so female child presented with a history of culture proven urine episodes of febrile UTI. She had a history of straining while passing urine. Her general health good, weight 9 kg. She is 11 months. Left bifid pelvic access system with moderate left hydroureter nephrosis up to the bladder, left lower ureter dilated, thin membrane-like structure. So you are seeing this. I'm not going in the detail. This is renal level sonography, and this is the bladder level, right? So this was the report, and then this MCUG again VCUG. There is no reflux again, but it almost confirms the presence of ureterocele. It's not very good kind of a study, but this does happen in the child when we do VCUG. See, so Professor Pathak, what is possible diagnosis and what is next when you have a 11-month female child with probably ureterocele on the right side with both the moiety showing the dilatation and no reflux?
Yeah, well, it's slightly unusual now, with VCUG showing no reflux, and the entire kidney is dilated, both the upper and the lower moiety.
But sir, this is explained. The ureterocele sometimes can stretch the even lower moiety ureter and can give rise to
Yeah, so primarily now the ureterocele is there. So my main goal would be to treat the ureterocele endoscopically by doing a cystoscopy and incision or puncture of the ureterocele.
So
and then
I'm giving you, before that, I'm giving you, sir, this renal scan picture. And here you can see the left this side is showing a obstructive pattern. That's okay. Split functions are like this, and this was a delayed pictures on the you can say the left side, and here also post-void and 2 hours pictures. So upper moiety shows some significant amount of function in the scan. With the both the moieties are dilated and no reflux. You have a situation like this.
So primary the goal treat the ureterocele, and that is endoscopically by puncturing or incising the ureterocele.
Sir, patient is absolutely fit, doing well, perfect. Still, you will prefer to put an incision in a hope that she might not require further any management, or for what reason? Yeah.
The reason is there is obstruction, there is dilatation. Okay. You are showing a renogram with obstruction.
Right, sir.
There is ultrasound showing a ureterocele over there. VCUG shows no reflux. There is a shadow.
As Ram was saying, sir, will you consider a definitive reconstructive procedure, means the excision of ureterocele and reimplantation?
Presently, I am not planning any reconstruction. I'll only treat the ureterocele endoscopically and then follow up the child.
And if the child is doing well, you will not further investigate?
I'll take as the things go. Means I'll just...
Okay, perfect. So I just tell you, this was the cystoscope. This was the options there. That the cystoscopy, endoscopic incision, open surgery, excision of ureterocele, and common C3 implantation. Observation maybe sometime. Now cystoscopy, just left-sided large ureterocele, small opening seen on the dependent part, second opening seen on a roof, which was very much also stretched laterally and canally on this thing, and was little bit everting on filling of the bladder. This was the cystoscopic my impression, and I went ahead with this definitive treatment sort of thing. Here you can see that this is a ureterocele, and there you can see this is the lower moiety ureter, and this is the upper moiety ureter Both are almost terminating here. And after the excision, this you can see the common sheath is very much well maintained. And then I did a common sheath reimplantation. And this is the post-operative MCU not having a reflux. And this is just recent. This is 12-year, almost 11-year post-operative follow-up. This is the renal level kidney sonography, and this is a bladder level. This is the common sheath reimplantation area. So, Ram, would you like to comment?
Yes.
On a management issue?
Yes. So I want to make a point is that there is sufficient evidence that if you go and puncture an asymptomatic ureterocele, you're creating more problems. You will create reflux as well. The real evidence for trying to puncture a ureterocele is in terms of sepsis, as we talked before. Except in orthotopic ureteroceles, you might do some benefit, but really in ectopic ureteroceles without infection, endoscopic correction is not a definitive treatment whatsoever. You will come back to do something else. So this patient, it depends if he's got reflux or not, either ipsilateral or contralateral, right? So if that's the case, primarily if there is any evidence of reflux, I will go for elective ureterocele excision and common sheath reimplantation at about 18 months of age, and the child is old enough, and I would do it preemptively. That is definitely evidence-based.
Ram, in this case, there were no reflux. Both the moiety showing the obstruction, and she was kept on antibiotic prophylaxis. See, now here, would you like to continue with the observation till that age, or you will make a punctures, or you will do a procedure like which I have done?
No, what I'm trying to say is that if you do a puncture, you will cause reflux.
Okay.
That is why I would do a reimplantation excision, especially if it is entering in towards a bladder neck into a large ureterocele, then I would reimplant in a common sheath. Yes, exactly what you've done. Yes.
Okay. And what you will do for the detrusor deficiency, you will do a good detrussorography.
I will show you the video.
Okay, perfect, perfect. So now it is gone to the all four remaining faculties. Margit, you do a first comment on this. You have a couple of your slides. You just can go run with this.
Go forward, because in this case, forward to the next slide.
Okay, forward. Okay.
I would do what Ram mentioned. No, that was the right one. A lower,
okay.
No, back again.
Okay.
Lower tract reconstruction. That means resection of ureterocele and neo-implantation of both ureters. And there are also some data out that show that kidney function is maintained in 94% and only 13% of complications. I also agree there is only one indication to puncture a ureterocele, and that is sepsis.
Sepsis.
Ram, your friend.
Well done.
Oh, why you are not mentioning me? I have done the same kind of a thing, probably. Only thing is that I was to start with extravesical dissection. Thereafter, I open the bladder because I have to go right up to the ureterocele, excise everything, detrussorography and common sheath reimplantation. And there you can see, you can read the date. That is 20th of the 7th month, just 2 days before. And this is 11-year post-op. She's doing perfectly well. She's my neighbor. Okay. So any Professor Manoj and Supul, you too.
Yes.
And last comment from these Ansari sir. Yes, please go ahead.
Yeah. So the first thing, asymptomatic ureteroceles, I wouldn't touch anything.
But this was a symptomatic, yeah.
Yeah, asymptomatic ureteroceles can be managed expectantly. Perfect. I disagree with what Ram was saying. He says evidence-based, that's fine, but I don't agree with that. So we have to think about what is it that we are trying to treat here. If you're creating reflux, how does it matter? Just because you can do something doesn't mean we should do something. And there is no data which shows that you have to do an excision of ureterocele and reimplantation. There is a risk of incontinence when you do that, because as I said earlier, by definition, the ureterocele in a duplex system.
Sir, have you seen that phenomena of incontinence in a unilateral pathology? Or you are fearing that more often with a bilateral sort of thing, or bilateral, you can say ectopic ureter, a single system ectopic ureter, or sort of this.
No, not a single system.
But because the single system, I have operated a couple of cases, but I have not feared about the incontinence, and I had no incontinence.
Yeah. So his comment that we should excise the ureterocele and reimplant, I do not agree with that at all. You can do an upper tract procedure if you wanted, but I'm not sure why, on what basis that is.
In this patient, what you would have done? So this is the USG picture. and patient was having
if the
pain and
child is
symptoms.
asymptomatic,
No, the patient, I gave you a history, was a culture proven episodes of febrile
I would
UTI.
puncture the ureterocele.
Okay, so you go with the Hemant's
Okay,
method.
Manoj,
Yeah.
Manoj, just to counter your point is that what you're saying is that why should you excise a ureterocele? Is that what you said, that you won't agree with it?
Yes, that's correct, Ram.
No, but why would you not excise the ureterocele?
No, but if you give me the reason why you want to excise it rather than why not.
Sir, the
to.
pathology, pathology
you
mainly
said,
primarily there.
Manoj,
Sir.
you said incontinence is a feature. It's not correct because you cannot leave the distal aspect of the ureterocele well within down. You do not cause incontinence by ureterocele excision if done correctly. That is an incorrect statement to make.
Okay,
Sorry.
so Ram, you may be a better surgeon than I am.
I'll show you the video now.
It's okay,
I
sir.
need to see a video.
Sir, it is not like that. See, I told you yesterday only in our correspondence that there will be a lot of controversies here, and we will be learning from the discussing these controversies. Yes, please. So, Supul, your comments.
Thank you, Anil.
Yeah.
So the ureterocele puncture is, as everybody mentioned, is indicated when there is sepsis, acute sepsis, which cannot be controlled quickly enough with antibiotics. Now, if the child is asymptomatic subsequently, no further urine infections, I would simply monitor the child with the regular ultrasound scans. Now I'm monitoring for two things. I'm monitoring for urine infections. I'm also monitoring for bladder outlet obstruction due to the ureterocele. If there is an indication of the lower moiety or the contralateral side dilating, if there is delay in toilet training, or if there is history of straining to pass urine, then I would have to consider it as possible obstruction by the ureterocele of the bladder outlet. In that case, I would happily go with Ram in removing the ureterocele and doing a new ureteric reimplantation if the upper moiety is also functioning quite well. Now, if the upper moiety is functioning poorly, there is a very good case for just the upper approach where, as Manoj mentioned, you would do a upper moiety heminephroureterectomy, removing that ureter pretty much right down to the bladder, suctioning inside the ureterocele and leaving it open so that it would all collapse and then become more normal. So you may remember all the controversies over the years.
The problem is that if you leave a poor functioning kidney, you have a fear that there can be a recurrent infection, there can be a hypertension, there can be some other issues. Is it that a real fear for doing such a huge excisional procedure where we are risking the lower moiety also?
The risk to the lower pole is given as 5% in the literature when you take all the literature, and then if you are experienced surgeon and if you select your cases nicely and careful, then the risk would be much low. But as I mentioned, this would be only done if the child is symptomatic.
Perfect. But here the kidney was upper moiety was showing the function, right? And child was symptomatic. So we got your point, right?
Yeah.
Right, sir. So would you like to add anything on this particular case? Otherwise, I go for next one where we will be able to complete this discussion.
Anil, I have to leave now.
Yes. I
before
really.
Margit goes, just one quick point about Supul's point is that heminephroureterectomy is okay. But the fact with David Keane, who is colleague in Manchester, who worked with me, we've just published a series, top-down or bottom-up approach. Even if you do an heminephroureterectomy, if there is ipsilateral or contralateral reflux, you will come back for bladder reconstructive procedure. There is the risk of doing an heminephroureterectomy in those circumstances because you'll be leaving a lower stump in there, which is refluxing and causing problems.
Anil Ram, the risk for lower tract surgery after heminephroureterectomy is about 5%. If you do a good ureterectomy, it is about 5% of the children would require lower tract surgery. And when you consider the all-term data, people used to do lower tract surgery quite a lot, full reconstructive approach. And then people used to get bladder problems where the bladder wasn't working well. That is the reason that people went to upper tract surgery, right? Now it is like this in the world. You go to one side and then you come back to the other side. So now we are coming back to lower tract surgery again. And after a while, you get enough patients with bladder issues, and then you will go back to the upper tract approach. This is the way it happens. It just turns up and down. You go from one to the other.
Okay. We'll continue.
Thank you, Margit.
Ram,
Thank
please.
you, Margit.
Yeah,
Thank you,
so
Margit.
we'll come to that discussion.
Goodbye. Thank you. Was fun again.
Margit, last sentence from me. Margit, I really, on behalf of ULTO and Euro Academy, we are extremely thankful to you being with us for 3 consecutive time in last 2 months. We are very much enlightened, enriched with your comments. Most of the residents are posting a lot of positive comments on your the slides and all those things. So thank you very much. And with that, probably we are ending up with your series with you, but not this discussion. We may continue for another half hour with your permission. Margit, you can leave.
Okay,
thank you very much.
Thank you for all.
Thank you, Dr. Margit. Okay, thank you.
So we continue here, and Ram and both the other teachers were debating, and it's an excellent debate. So before we end the debate, let me introduce the last 2 cases quickly. Not going to ask, just quickly to have a furthermore broadened discussion on this. So this is again 3-year female child, history of febrile for 3 times in last 1 year. Antibiotic prophylaxis by pediatricians, examination normal, creatinine is also normal range. USG at renal level, you can see significant upper polar dilatation, lower pole is normal. And this was the voiding cystoscopy of this patient. This is the pre-void picture, and this is almost at the end of voiding. There you can see that there is some reflux there on the upper moiety ureter also. So, and this is the DMSS scan. Here you can see that you can do not see any activity here on the left side, sorry, on the right side, on the top of the kidney. And you can see here even in the functional percentage, left is 63 and right is 36, and the counts is on the left 127 uptake counts, and right is 67. So here what we will discuss is that again this child is symptomatic, and we have plenty of options. Common C3 implantation, upper or lower UU with lower ureter implantation, because we have to take care of both refluxing intrauterine segments. So just I'm summing up this case. We'll come back if you need these slides, and going to the last probably case, that is of a duplex system with upper moiety, which is ectopic insertion but no incontinence, and upper moiety only dilated with the function is there. And this is again, there was a CT scan done in Ahmedabad. Here you can see that massive dilated upper moiety ureter. Lower moiety is practically normal, and there you can see the functional uptake is there also on both this here also in this page, this picture also. And we'll discuss also the diagnostic treatment approach for this. So would you like to discuss first this case, Ram, or you want to continue with the debate?
No, you do what you're the host.
Okay, fine. So let us finish the management option of this case. This is 18-month female with right duplex upper moiety ectopic ureter with obstruction. She was presenting with the pain with this dilatation. And what you would have offered, Dr. Manoj? Manoj.
So,
what you would have offered? Yeah.
So if the child is again symptomatic, means one of the option would be if it's an upper pole.
I just add one sentence that this patient was offered heminephrectomy with ureterectomy as much as possible, and then this patient came us to my friend's hospital in Ahmedabad, where I am also joining in some of the we doing together work, and we treated it differently. So you please go ahead.
Yeah, so one option would be to do a lower end, like Rama Jayanti and people have said, you can do a ureterostomy at the lower end.
That what exactly we have done in this case. There you can see that this is the lower moiety ureter is opened up, upper moiety ureter was cut at the inguinal level, approach we were inguinal level, and then it was anastomosed. Yeah, please go ahead.
Yeah, so that's the option I would choose, and leave the stent in the lower ureter for some time.
Yeah, so that exactly we did. We did prior stenting, and then we went ahead with this approach. Is very small incision. Both the ureter are quite accessible from here very easily, and this surgery can be finished very quickly. And and we have a couple of cases with a good result, but not long-term follow-up. We'll definitely wait for the long-term follow-up. Agree with Supul, you want to have some change in this management option? Supul?
Just a second, I'm just unmuting my mic.
Okay.
Right?
Okay.
I think you've taken a very good option in a lower ureterostomy. Now, again, as you have mentioned, we need long-term data as to how successful this is.
Perfect.
And one of my colleagues is quite like to do this one. And there were a number of children who had recurrent UTI afterwards because there is a dilated system, and we are creating something called yo-yo reflux. Yo-yo reflux, I mean, you all know, where urine goes from one ureter to the other ureter and then comes back from that ureter to the other ureter. So it's urine is just fluxing between the two ureters, and especially with when there is a dilated ureter, this would lead to stagnation and possibility of infection. So how you do it and what's the result, it is up for discussion till we get the long-term data about it.
Sir, I think by this time we have a many number. This is a 2019 article of Journal of Pediatric Urology, where there are so many other references were there. I went through the couple of these cross references, and there is probably few of the people. I was also not knowing that exactly people are doing these procedures probably more than now 20 years, and they said that they have a follow-up up to 18 to 20 years with a good outcome. I don't have, and I see those kind of patients with where you have preserved the upper moiety, one or another reason. As I am having a equally good amount of reconstructive procedures of elderly patients, and I have seen they're forming the stone, and they come with the again, and then I have to do a line of the stone in the ureter, and I just missed putting that picture, but I agree that we need to have a long-term our own follow-up.
I mean,
please.
as you said, it is a great procedure if the long-term results are good, because it is such a simple procedure to do, doesn't take much time, excellent recovery as well. So it would be really good to have that proper long-term data follow-up, and then to see how the results are. Yeah.
Hemant sir, your approach for this case?
Actually, for a few years, I used to do upper tract. I mean, I used to do a ureteropylostomy, but now recently, I've gone. Many of us are presenting this lower tract. I mean, ureterostomy. So I have done a couple of ureteropylostomies laparoscopically, and all have shown good results.
Okay. Ansari sir, before I go to the Ram.
Yes, because ureterostomy is a good option. But beside the yo-yo reflux, why to put surgeon into trouble going deep down in the pelvis? Why not to do a high ureterostomy? Iliac crest is a very easy level. You do it there. It is not non-refluxing ureter as well. Why to go down into the pelvis? And very good, it can be done by robot or laparoscopy.
Ureteroaortic anastomosis. So you agree with the ureteroaortic, but little higher and laparoscopically.
Not the lower. Go to the aegis side. Aegis side will be somewhere along the iliac crest.
Sir, can you reduce your volume? It is echoing. Little bit reduce. Yeah, please. Yeah. Okay. Go ahead.
So I was just saying.
So in this particular case, you would have done laparoscopic UU up almost at higher level.
Yes.
Above the sacroiliac border.
Yes.
Okay, fine.
And it is a non-refluxing ureter also.
Yeah, it is non-refluxing. This particular case we are talking, and that will be your approach. Okay. And that is your routine practice, or at times you do upper pole heminephrectomy in these kind of cases, as it was advised by some other urologist, as upper pole uptake in this scan is just around you can see 3%. Sorry, no.
Yes, even if it is 0, if the child is asymptomatic and it is an incidental finding, upper pole heminephrectomy or intervention is not at all needed.
Okay, perfect.
Autopsy studies have shown even ureteroscopy has been seen in adults, 80 years, 70 years. So they went asymptomatic. So in all cases, you need not to intervene unless the child qualifies for intervention.
Okay, and Ram, you are the last person. You can take 1 or 2 minutes for summing up the discussion on your approach.
Well, I would do a common sheath reimplantation. The main problem I have is that sometimes, or many times, I've seen that the corresponding ureter is of extremely small.
This ureter is hugely dilated as you go lower down.
I know. The other problem then you have also is that the contralateral ureter is small and the discrepancy between the ureter size is quite different. So then you are risking an anastomosis in these extremely fine ureters sometimes. So not all cases are suitable for ureterostomy, but I would rather prefer to do a reimplantation. And if I have to taper one ureter, I will do it. I will still do a common sheath reimplantation.
So the literature say that it is double the normal one. It is perfectly okay in their long-term follow-up. You agree up to that level, means double than the normal one?
Yes, I would. I am quite happy to do a tapered reimplantation, but in the common sheath, no problem.
Okay, perfect. So in this particular case, we have taken. So just now this management of the last case, quickly going that upper moiety is not showing any uptake in the DMSS scan, and we have a couple of options. And in that case, I went ahead with this exploring extravesical again, and to my surprise, because of too much of dilatation and too much of length, which was ureter was almost reaching up to the bladder neck in this girl, and upper moiety ureter. Investing sheath was very much thinned out, and probably it could be separated almost very easily, maintaining both the vascularity very well. So I tapered the upper ureter separately and then reimplanted both the ureter separately. And this is the follow-up single plate IVU at the 6 month, and MCUG also was not showing any reflux. So, Ram, you agree with this kind of a management, or again you differ in this case?
No.
This I explore, keeping in the mind that I will go ahead with the common sheath reimplantation, because I have to deal with both the refluxing moiety ureters. So even if I go upward and do heminephrectomy, I have to go right up to the down to excise this upper moiety ureter right there. So I am risking again there. So rather risking directly there, I think that let me explore first at the down and then see that how these patients
this is very good approach. I would happy with that. Yeah.
So Manoj and Supul, one by one. Yeah, please.
No more comments to add. Actually, I think it's been everything that needs to be said has been said. Just one comment on what Supul had said earlier. So Rama Jayantri from Columbus presented at the ESP. I think it was, Ram may remember this. I think it was last year, the year before, on about 50 odd patients with lower ureterostomy, with good results, with no obvious complications. So the concern about yo-yo reflux is not all that valid.
Yeah. So the article which I have posted here, reference is from the Rama, I think, which is published probably in the 2019. I agree. Yeah. Okay. And you agree that sometimes this dissecting and separating these two moiety may be surprisingly easy if the common this investing sheath is thinned out because of this disproportionate dilatation in the length. Because one was attached at the orthotopic position, that was a lower moiety, and upper moiety ureter was going quite far down. Manoj and Supul.
Yeah, I would agree with that.
Okay, Supul, your comment on the management. See, here I tell you very frankly, in the long-term follow-up, that is of almost 4 to 5 years, this patient came again, not with any kind of other symptoms other than the lower urinary infection, means of febrile UTI, of it twice in a first 6 to 8 months. Thereafter, she has never turned again for that complaint, but she is in a very good follow-up. Yeah, please. So one of the fear and one of the when we discuss this, that you are keeping almost non-functioning upper moiety here. So and your one of the indication of surgery was the recurrent febrile UTI with that she present. So there was bit controversy when we took a decision of operating this patient in this way. Yeah, please, Supul.
Unmute.
Yeah, Supul.
Sorry. I got a call from a patient.
So no problem. You was listening the comments which I have done.
No, sorry, Anil, I missed that one.
Okay. Okay. So the thing is that here to start with, the upper moiety was poorly functioning or almost not showing any uptake.
Yeah.
In that case, I took a decision like this. To my surprise, whenever I see such a dilated ureter, I always feel that there is no dysplastic moiety above. Maybe it was only obstructed, which is seen in the sonography very well, right?
Yeah.
And in that circumstances, you are having an improvement into that upper moiety function, though it is not showing any uptake. It's still there, and we can attempt this kind of a reimplantation procedure. Yeah, please go ahead.
Yeah, I mean, if a DMSA scan is showing that the upper moiety function is really poor or is not there,
Yeah.
I don't think by allowing the urine to drain better, you would still improve the function, right? It is.
Okay.
It is.
Okay.
Yeah. So I would not think about major reconstructive surgery if the upper moiety is not functioning. As Dr. Ansari mentioned as well, only reason to do anything would be if the child is symptomatic.
Yes, symptomatic. This child was asymptomatic, came thrice for the febrile UTI, was having a pain. She was already 3.5 years. By the time we operated, she was almost 4 years, and she was persisting with the problem. Yeah.
Of course, right. So we are doing the operation for symptoms rather than with a view to improving the function.
Perfect.
So if you feel that the common sheath reimplantation is what you would like to do, that you would do it. And if somebody feels that it's a ureterostomy with very good results on the long term, without.
Sir, but here you have both the moiety refluxing. We are discussing that scenario. Both the moiety showing the refluxing thing. So if you do a UU, you have to do that lower moiety reimplantation again. And probably as per the literature, even for Rama Jayanti, that the chances of failure or having some complication increases when you add ureteric reimplantation of one of the moiety with a UU.
Yeah, Anil, my apologies. I didn't get that point about the reflux to both moieties, right?
No,
agree.
Yeah.
It has to be a common sheath reimplantation, and that would work wonders. That would be great, right?
Okay. Perfect. Dr. Ansari, you want to make a comment on these patients, how you would have managed? Again, you would have preferred this upper pole heminephrectomy going as down as possible on upper moiety ureter as it is refluxing, or you would have done at the bladder level surgery?
So because both the moieties are refluxing here,
yeah.
So I think I would just go, and the function of our moiety is still there. Yes.
No, sir. Upper moiety is not showing the DMSA much of a function.
No, not of a function. Then obviously it will. Even if it is non-functioning, there are some interesting literature on it. Even if it is non-functioning, people have done ureterostomy and the functioning moiety reimplantation. And it's so interesting you find when you go to the literature.
But sir, but with that, there is an increase in complication in compared to the common sheath reimplantation or occasionally reimplantation of both.
Why do you think, if at all that non-functioning kidney causes problem, retronephrectomy can be done at any point of time?
Yes, sir. But suppose what you will prefer here, UU with reimplantation of lower moiety ureter, one option, or you would have preferred common sheath, or by chance you are able to separate too easily, then you would have preferred to do
common sheath only. See, the common sheath only exists in the lower ureter. It is very thin. If you go just above the iliac crest, it is hardly seen. It is a very thin membrane. The only worrying point is that the upper moiety is non-functional. That is attracting our attention. So whenever we see that the moiety is non-functioning, the first question in our minds comes that ablate it, remove it. But people have done very interesting study. What they have done a non-functioning ureter moiety into the functioning ureter moiety, and
perfect,
the refluxing moiety has been single.
Sir, if you do here ureteric anastomosis with the reimplantation of the lower moiety ureter,
yes,
how you will deal with the lowest most pass of a refluxing segment which is there in the ureter in the bladder?
Then you reimplant it now. Ureterostomy and the reimplantation of the recipient ureter.
No, but upper moiety you are not separating right up to lower end.
Whenever you deal with the duplex system, little bit separation of the common sheath always occurs.
So you want to say that in these patients, still you will prefer uretero-ureteric anastomosis with the reimplantation of lower
With
moiety ureter
reimplantation.
rather than tapering the upper moiety ureter and doing common sheath reimplantation?
Yeah,
or
yeah.
by chance you have a good easy separation, you separate it and then taper the upper moiety ureter and reimplant both to separately.
It does not cause little bit separation.
Okay, Ram. So now Bhagwan Ram bolte na in India. Last option is the Bhagwan Ram.
Yes.
Yeah. Yeah.
Yeah, I mean, believe me, I've lost the whole argument at the moment. So basically, you're talking about, I would do a common sheath reimplantation. I keep saying that. That's the point for me, is because didn't you say that both the ureters are refluxing in this case? Isn't that what you said?
Yes.
Is that what you said, Anil?
Yes. I saw it also. Na?
So straightforward, common sheath reimplantation. Common sheath reimplantation.
Here you can see that it is both the moiety refluxing.
Yeah.
So
cover
the complete spectrum. I kept all these kind of cases for better discussion. Yeah, please. So Ram, last question regarding the common sheath is that thereafter we'll have a last few comments that what worries or what care we must exert doing common sheath reimplantation not to fail, because people have a worry of a failure of a common sheath reimplantation and there can be a persistence of reflux.
Two things. Two dissection.
Point to be taken consideration.
Yeah, two things. One is the dissection has got to be maintained so that the vascularity is not compromised. So it's got to be truly in a common sheath, right? And the second important thing is that at the level of the anastomosis, you may have to adjust one of the openings, slightly cut down, widen it up, and then make both the ureteric orifices join together with a couple of sutures, so that essentially you got a bridge here, but there is a common entry into the bladder. I think those two important points, and then the rest of this tunnel and everything else.
Okay. And in that case, suppose if you have such a excess length, you can definitely take it out to make together.
That's right.
That's a good point.
I would excise.
And maybe that would have avoided even the tapering.
I would join them together at the entry point to make a single opening with a bridge in between. That's how it's put in.
Okay, fine. So probably with this we have covered all 7 cases which we have planned to discuss. And before we, I'm really interested to see your video. We'll allow you to share your screen. But before that, I would like to have a final comment from all of you regarding your experience about this webinar. Manoj, please.
Yeah, so Anil, firstly, thanks. And I think it was well conducted, good array of cases. We had kind of good discussion. It's important that all of us don't agree. I'm not saying we should actively choose to disagree, but what I'm saying is,
sir, I request you to go through the previous 2 webinars which we did with these various faculties, keeping Margit consistent. And you see in a PU wall, we had a severe amount of discussion and controversy. We could not finish the whole number of the slides in a previous, that there was a reflux discussion there also, but that has opened up many people to give to initiate this thinking about all those things. And there was subsequently we got many number of questions on the Facebook page and also personally on WhatsApp, and we have a very much good discussion. So young minds are getting encouraged with this kind of a discussion. There is no harm is there also.
Yeah,
just to inform.
Yeah, so that is important. So look, Ram and I go back a very long way. So people shouldn't construe that as, as was said, we are all good friends, and so there's no ill will towards anyone. But what is important for the younger generation to realize is there are different ways of treating conditions. And at the end of the day, what we should ask ourselves is, what is it that we are trying to treat? We should treat the patient, not X-rays, not ultrasounds, not CTs. So that's the take-home message for me.
That's very important message, at least for pediatric urology. Pediatric urology is a wide different subspecialty. The reason is that that you cannot take a decision on a first radiological impression. You have to just sit and talk with the parents and go in the detail of the each and everything of the patients, and then only you have to take a decision. Yeah, sir, agree. Well taken point, sir. Supul, sir.
Hi, Anil. Again, thank you so much for inviting me, and thanks to Max also recommending that I would join, because he's enjoying on seaside in island in Italy. So he wanted me to participate in the discussion. And I agree with what Manoj mentioned. We are treating the patient, not the images. And then we disagree amicably, even when we disagree, because it is with our expertise, with our experience in handling patients for a long term. So we know what works in our hands and what doesn't work in our hands. But we should be open to things that we don't do, rather than be in a closed shop. And as Ram says, it is good to have one or two good operations that you do regularly, and then really have long-term data. And then Ram mentioned about the common sheath reimplantation, ureterocele excision, and then surgery. So if somebody feels happy doing that, and that is what that person got to do, because that provides the best results for their patients, and that is what they are comfortable with.
Okay. Okay. And I really thank you both for your cooperation, your comments, your enlightening comments. And I promise, and I want your promise also, that we want you again to come, maybe on this platform or another platform when we arrange some bigger meeting where I would like to have both of you, sir. So Ram, would you like to comment?
Yes, I want Dr. Ansari's Lucknowi either kebab. I want kebab, okay, as well as some biryani.
Okay.
Dr. Ansari, next time. Sorry.
Okay. Okay.
We
hope that you enjoyed, Ram.
Yes.
Ram, we hope that you enjoyed.
Yes. Yes.
Ani,
Yeah.
I heartily congratulate you. Actually, we have been only the panelists. The hard work which you have been doing in getting the cases.
Sir, Hemant sir, thank you very much. This is just all because of you initiated in me all these things, and I am always your student. If I'm sorry if I'm not come
all your
very
hard
frequently
work
to
has
you.
been shown the good results here.
Thank you very much, sir. Ansari sir, your last comment on this webinar, and then we switch over to the Ram for his.
I am eagerly waiting for Ram's video.
Okay, perfect. So with that,
yeah. So I just want to say, Anil, that you've done an exceptional job. The level of discussion was very high. I enjoyed a lot. And like my colleagues say, one of the ways, if you want to do really good for your patients, and when we grow up, we understand that you are allowed to, you agree to disagree. That's the term. Do you understand? So you can say, okay, I don't believe in this or believe in that, because everything what matters is improving the quality of care you give to your patient. So all three of us are saying the same things. Right. You must not be scared to speak out if you don't believe in something. That's absolutely fine, and that's what
if you ask Manoj, yesterday only in our conversation, I informed him that there will be a lot of controversy, and be prepared for that, and that will encourage young minds to think a lot about all those things. We differed a lot in previous couple of webinars, and I really enjoyed. I never worry about the controversy. We should take best possible for the patient in the best possible way in our hand.
Yeah.
So
Anil,
thank you very much, Ram, to come over here. Yeah.
Anil,
so I stop my screen share, and thereafter you can share the screen. And with that, I thank you all of my faculties very much, and also thanking ULTOE, a superb platform, extraordinary platform to give this opportunity to conduct this webinar. Thank you very much, Nitesh and your team. Thank you very much.
I'll show this video, and I hope I can convert Manoj to do some ureterocele excisions.
Ram, just a comment on that. I've inherited some disasters from my predecessors. So
I'll show you this, okay?
No, I'll come to Leeds once, Ram.
So I'll show you the video now, so you can see.
No, I need to leave, Ram. I really need to leave.
Okay, see you. Okay,
yeah, but I'll come one day. Yeah. Thanks. Take care, everyone. Bye-bye.
Okay. Thank you, Dr. Manoj.
Thanks.
Thank you, sir.
Bye-bye.
Can you see now?
Yeah, you can share your screen. Yeah, please.
It says disabled. I can't see. It says.
Okay. I have to. Nitesh, if you are there, are you there? Can you make Ram a co-host? Nitesh, give me a minute. You can continue your talk with the your friend by that time, Ansari.
Yes.
Hey, I'm missing you, Ansari, in ESPU meetings.
So maybe sir, this year it has been, I think, further postponed now.
Nitesh.
And there is, sir, yes, I think I'm
It
planning
will
for
be
a
in April.
virtual
It will
conference
be in
also.
April. A virtual congress we will have in November, but April
year
will
also
be the
virtual?
main meeting. Yeah, April.
Okay, for this
April
year.
in Lisbon is a ESPU meeting is postponed.
Okay.
Yeah,
You,
so-
you are not reading, that means emails, which
Why?
No,
I'm
I'm
talking
reading,
to
but
Ansari.
still, see, I'm talking to the secretary straight away now.
Secretary sent the 2-3 messages already on
Yes,
canceling
yeah.
this meeting right now and on April.
Anil, I have sent you a private message. We need to meet in Junagadh and do some
Oh,
upgrading.
yeah. Perfect. You are most welcome. And Junagadh is beautiful right now. When it is
Oh, is it?
raining, it is absolutely tremendously beautiful. Only thing is the city is not well managed.
Yeah.
But otherwise, it's a great place to come in the monsoon. We have a lot of natural spots where we can go for a trekking and have a open bath into that falls. People enjoy like anything. They are really virtually mad about it.
Can I share now? No, not yet.
I'm trying to connect with our webmaster.
Ah.
Still, you are not able to share the screen.
No, it says host disabled attendee screen sharing. So
Okay.
I'm disabled.
Yeah, no. Nitesh is. We have kept Nitesh very busy. So today is one of the close relative developed get the corona. So he went there hospital to admit him. That's why he was running from one or another corner. But very soon, I think.
Oh, allows you to record.
Hello,
okay.
Nitesh.
I think he can try now. Multiple part. Dr. Ram, you can try now.
Yeah. Okay. Yes. Okay. Fine.
I've done it from here.
Can you see now?
Yes.
Yes, we can.
Yes.
Yeah.
Okay.
Go ahead.
It's got the audio and the music and everything. So just 6 minutes. Listen to it. Okay. Yeah.
Okay.
Demonstrates a safe and efficient technique of ureterocele excision in duplex systems. A case in point is a right duplex system with a ureterocele and a dilated ureter behind the bladder. The left kidney is normal. Please note reflux into the right lower pole ureter. This is the DMSA isotope scan of the same patient. The lower pole ureteric orifice of the right duplex system is identified. The dissection is begun by mobilizing the lower pole ureteric orifice on top of the ureterocele. Please note the vas at the level of dissection. The aim is to reach the entry point of the duplex ureters into the bladder above the ureterocele. The duplex ureters in the common sheath is isolated and held over a sloop. The vas, which was identified during dissection, is shown to be clearly protected. The mobilized duplex ureters within a common sheath have been divided proximal to the ureterocele. The ureterocele is then excised as much as possible, leaving the very distal end in situ to protect nerves at the bladder neck. The detrusor defect is now approximated, providing adequate support for the reimplanted ureters. The dilated upper pole ureter is tapered. Excisional tapering is completed with interrupted 6-0 PDS sutures. The neo-duplex ureteric anastomosis to the bladder is completed. Note the feeding tube in the lower pole orifice and the forceps in the upper pole orifice. The detrusor mucosa is then approximated to complete the repair. Please note, a proximal suture is incorporated into the ureter to maintain the tunnel length.
Hello.
The duplex ureteric reimplantation is now completed in a safe manner. The contralateral ureter is ensured safe. Postoperatively, in the patient whose images were shown before the video, demonstrates normal upper tracts which are non-dilated and safe. And the bladder is thin-walled with no residual ureteric dilatation. Also note that the bladder emptying is complete as shown in these scans. In this series, there has been no clinical evidence of bladder dysfunction. One girl who had bilateral ureteroceles had recurrent urinary tract infections postoperatively, demonstrating deflux into all 4 reimplanted ureters and needed an endoscopic correction with deflux. She's currently well. So yeah, so that's what
I have a liberty to raise the 2 things. Excellent video, and already comments are pouring. You can see in the chat box also, and the Facebook also. The thing is that what exactly I tried to show in one of the case of a common sheath, this excision with the common sheath reimplantation, is that I approach extravasically and then enter into the gradually in the bladder. I think that also can be done, but that what you demonstrated is probably much easier to
what I want to
replicate.
Anil, what I want to say to the people, the trainees particularly, if you want to try it, is that people are very scared of excising ureteroceles. A, for causing bleeding or going down to the bladder neck and doing some work there. The aim should be to go to the lower pole ureteric orifice, go to the entry point in the bladder, and then work downwards as my subsocial excision. Leave the ureterocele in the pelvic region or down in the bladder neck, because that doesn't matter. It doesn't cause any problems. That way, you don't cause bladder dysfunction. and you feel confident. And the same, that's what I was trying to explain all along, that you don't need to worry about ureteroseals.
Absolutely agree. I'm absolutely agree that not seen any vesical dysfunction with this kind of dissection and operative procedure. I have not seen. And I have working in the single center for more than 20 years, like you, right? I have a real good follow-up. And whenever I call those patients telephonically, they do come. So whenever
if you want to, Anil, in the future, I have, I don't know, hundreds of all well-edited videos with 5 minutes, 6, so that it's all sharp and you don't have to waste time seeing them. A good video demonstration workshop also is very helpful for people.
We'll keep definitely.
You can see
we'll
those
consider, yeah. It's open for comments from others. Yeah, please. Pathak sir, you wanted to comment. Sir, you unmute yourself, sir, please.
No. Yeah, good technique. Made it look, very practical. And as you mentioned, you don't have to go down the fear which is there of reaching the bladder neck. You have obviated that.
The thing is also, it's a difficult case, you see, a big ureterocele getting down there. So it's a proper demonstration of a good case rather than just a.
Yeah.
Ansari Saab, आपका verdict क्या है?
So I just wanted to know, because small ureterocele, so I agree. Do the large ureterocele cause any damage to the bladder dysfunction on long-term basis?
It shouldn't, because it is sitting all in the planes there. So if you don't cause any surgical dissection, we haven't seen our series so far. It's actually really works quite nicely, this technique.
Because we are no more near the bladder neck, actual true bladder neck. We are not almost, Aram, I think we never go right beyond or up to the bladder neck reach, that typical one, I think. Yes,
I think it was, yes, excellent.
One more question, Ram, is that I really surprised to have a deflux, have some response in this kind of a situation. I think if there can be some UTI, but if there is a persistence of reflux with the UTI, then you get away with the deflux, but otherwise
you don't. Very rare. You're right, Anil. Yeah. This is exceptional circumstances I found myself in. I had bilateral large ureteroceles. She was in trouble. I did excision of ureteroceles, the reimplantation, and all the 4 started refluxing, and she was getting recurrent infections. Believe me, it's a nightmare of a case.
What do you think that the reflux, because of you did it bilateral and there was some compromise in your tunneling because
Possibly.
of you did a bilateral?
Possibly, absolutely, and that was a problem. But anyway, large ureteroceles, bilateral, to accommodate in the bladder, the reflux mechanism did not work, and that's exactly what happened here. Okay, so but it's very rare. I tried it to deflux, but it worked for a little while. At that video of presentation, it was okay, but after that, she again got infections, and I had when one kidney lost its function, so I had to take it out. But that's an exceptional circumstances. But vast majority of other cases, it's not. We are not. This is not the experience.
Excellent. Agree.
Supul, any comments?
Well done, Ram. That was a beautiful video and a very good demonstration of the technique. And I think you highlighted that you got to stick to the real actual serosal wall of the ureterocele itself without going out. I think that is the most important thing to do. And then you are pretty much removing most of it apart from going down to the urethra that you have to again mention, right? But that is where the damage occurs. Yeah. Well done.
Thank you. That's what David Keane was writing up, you see. He was working with me and he had seen these procedures. And that's why we came about looking at it up. So.
Yeah, great. Good job.
Thank you.
Sir, Ansari sir, your final comments so we can meet next time very soon.
So what can I say? I'm so pleased and happy to have the great teachers and who have been influencing all of us over the last 2 decades. So we are lucky to have Dr. Ram, Dr. Supul, and Dr. Manoj, and even Professor Anil Takwani also, along with Dr. Pathak.
Yeah.
So I really thankful, and I should thank Dr. Max also, roping in Dr. Supul so that he could feel how nice, how cordial the Indians are, and we have very big heart. And yes,
I have been to India many times. I was a pediatric surgeon in Sri Lanka. I have visited
Okay,
India for pediatric surgery congresses and things. It's
So-
I have a soft corner for India in my heart. I love
You
the
should,
people
yeah.
in the country.
You are.
We love your comment and your patience in listening others and as well as commenting with the patients. I had to learn a little more from that because I
Lucknow
go
is
on
not
doing
so
this kind
far.
of a webinar where I do convener sort of a moderating sort of a function for many of the frequent time, and I learn from people like you that how to handle this thing.
Thanks, Anil. Great job again. Well done.
So with
Thank
that,
you, Anil.
yeah, goodbye to all.
Okay,
Good
thank
night, and
Thank you.
stay blessed. Take care of all of you, and bye. We'll meet soon. Thank
Bye.
you. Yeah,
Bye.
thank you very much.
Thank you so
Anil,
much.
can you just send me just some sort of a email or some thank you thing, because I want to put my university.
Yeah. So I
when I
will send you.
participate in
We'll
the
send you the
webinar.
complete recording of this webinar.
No,
as a
I just
YouTube
want
link.
I just
What?
want like a piece of paper, sorry, an email suggesting that we took part in a webinar.
Absolutely, you will be getting a beautiful certificate, sort of a thing
Thank
that
you.
it is coming to you from the ULTOI and Euro Academy Group. Please, thank you very much. Thank you once again to all of you. Yeah, thank
so
you,
much.
sir.
Okay.
Sir
Bye.
Hemant, sir.
Yes,
Good night,
yes.
sir. Yes.
Good night. Good night.
Yeah.